Yeah, we are live. Hello and welcome. A very, very warm good evening to all of you who are here catching us live, and all of you who have joined us here on Zoom directly. We, over the last 1 week, we have been very proud to get in touch with the top 10 participants of the DNA quiz that we conducted for surgery residents for the entire country, and we have been able to shortlist, though it is not fair to shortlist only on the basis of one particular exam, but yes, we have been able to shortlist the brightest of the minds to participate in the second round. With me, joining me today are three of the brightest in the field, who have been guiding the brightest in the field for years now. I have with me Dr. Rajamahendran, Dr. Venkatesh, and Dr. Balaji here. Uh, and shortly we will begin the quiz. But before we begin the first round of the quiz, we would like each of the doctors who has joined us here, Dr. Ayush, starting from Dr. Ayush, to introduce themselves of, about where you belong to, where you are doing your residency, and what is your future goal.
Hello, sir. Thank you so much, sir, for this opportunity. I'm Dr. Ayush Badani. I just completed my residency. I've not completed my tenure, but I've completed the MS finals. Just yesterday, my results came. I am doing my residency from All India Institute of Medical Sciences, Patna currently.
Very good. Congrats. Yes. Next. Dr. Ayush Vyas, please introduce.
Good evening, sir. My name is Dr. Ayush Vyas. I am currently doing my residency from Government Medical College, Kota, Rajasthan. And
Welcome, Ayush. Very good.
thank you.
Congrats. Dr. Ayush Gupta, please introduce yourself.
Good evening, sir. I am Dr. Ayush Gupta. Currently, I am doing my final year residency Medical College and Hospital, Jaipur.
That's great. Welcome, Ayush. Dr. Sachin, please introduce yourself.
Good evening, sir. My name is Dr. Sachin Singh. I am from Ahmedabad. I completed my PG from PDU Government Medical College, Rajkot in 2023.
Great, Sachin. Welcome. Dr. Ganesh, please introduce yourself.
Thank you for this opportunity. I did my MS from BJ Government Medical College. There only I've started doing SRCs.
Congrats, Ganesh. Dr. Keshav, you are unmute yourself, please. Dr. Keshav is muted. Yes.
Hello. So good evening, sir. Thank you for giving me for this opportunity. I done my MS from SBS Medical College, Jaipur, and I am currently in SR in GMC Kota, sir.
Welcome, Keshav. Thank you. Congrats. Yes, Ravi, we can start the session.
Yeah.
Preliminary, we can start.
So the preliminary round of this DNA test will be conducted on Kahoot, and all of our participants have joined this Kahoot. Just to confirm, Dr. Ayush Badani, Dr. Ganesh, Dr. Ayush Gupta, Dr. Ayush Vyas, Dr. Sachin, and the name here is Rahul, but it is actually Dr. Keshav, who have joined. All 6 of our participants have joined the quiz, and I am going to start the quiz. Just a rule reminder for all the participants: wherever you have joined, the link that using which you have joined the quiz, on that screen you will have to answer the correct answer. Each question over here has 20 to 30 seconds time allocated to it, depending on the length of the question, and you have to choose the correct option out of the 4. If there is a correct option which being chosen by multiple students, all the students, or if all of you select the correct answer, the person who chooses the answer the quickest will be rated the best. That is the rules as per rules of scoring as per Kahoot, right? So you don't.
Ravi, sorry to interrupt. Ravi, Dr. Shashank is joining. Can we wait for 30 seconds, if you don't mind?
Yeah, he can join the quiz on Kahoot. The QR is already shared on the group.
Yeah, I'll brief.
Yeah. So each question here is scored out of 1000. If you answer a question in 0 seconds, you may end up getting 1000 if you answer it correctly. But for the same question, you will see different scores being given to different students. It is just like the fastest fingers first that you see in Kaun Banega Karodpati or any other online gaming that you have done. Right? So we are waiting just for Dr. Shashank. And as soon as he starts, I will be sharing the screen here. You will be able to see the screen on this question on this screen as well as the screen that you have joined that quiz from. I'm assuming PLEB is Dr. Shashank for the moment. Okay. Karthik, can you confirm if Dr. Shashank has joined?
Yes, Ravi. Dr. Shashank is on a call with me. He just scanned the QR.
Yeah.
Dr. Shashank, what is the name you have given on the QR?
Yes.
Karthik, can we start the quiz?
Yes. He almost is in. Kahut, he has already joined.
Yeah, you can start it. Ravi, you can start it.
Yeah.
In Kahut, he has joined, doctor.
Okay,
Okay.
ask them to attend the quiz. Yes,
Yeah.
you can start it.
So I think we have some of the people from our audience watching it live on YouTube also who have started it, who have joined it. That's absolutely fine. You can also answer the quiz. So here goes the first question. So out of all the people who have responded to the first question, we have 5 people who have given the correct answer, hyponatremia, while 3 of you have marked hypomagnesia and 1 of you have marked hypo. Oh, okay. 3 of you have marked hypomagnesemia, and there is one. This is what the leaderboard looks like after the first question. Dr. RRM was the quickest to answer. Dr. RRM, I request you to not take
I just
MHS
checked it, don't worry. I wanted to check the session.
Yeah.
Yeah.
Of the other participants.
Because
But among the participants, we have Dr.
Right.
Ayush, who is leading on 793, followed by Dr. Sachin at 693, Dr. Ayush Vyas at 606, and Dr. Ayush Badani at 592. So this is how differential scoring will happen for each of
Hello.
the questions.
Just a
Yeah.
question. Hello.
Yes.
The option is not showing on the phone which I am seeing. Only the diagram, or
Yes.
is it like this only, or it's something wrong with my interface?
You should be able to see the options.
No,
It's the same with me as well. Only the symbols are visible.
Yeah,
Option
only the
you have to see
symbols
on
are
the screen.
visible. Yeah.
You have to see the symbol and answer from accordingly from the book, from the laptop. So what is shown, no, you have to answer from the symbol.
Yeah.
Okay.
The exact answer is not seen on the mobile.
Yeah.
You are getting only the symbols. Accordingly, you watch the symbol and answer from the screen.
Okay.
Yeah. You just have to click on the symbol. That is correct.
Yes. Yeah, you can proceed.
So we have 7 of you who have picked the correct answer, CE2. And Dr. Ayush has gained his position and come back to the first position. Dr. Ayush Gupta stays at the second position. Dr. Rahul has also seen an increase in his score, and Dr. Ganesh also an increase in the score. Let's go to the third one.
Keep on going to the next question, Ravi. Keep on
Yeah.
moving. We will see after 5 questions.
Yeah. Four questions done. This is question 5.
Answer is iron in hemochromatosis. Yes.
And we see Dr. Ayush Gupta finding his way, coming to the third position. Dr. Ayush Badani is on a streak with 5 correct answers in a row. Absolutely breathing fire over here. I think this is the world of Ayushas and we are only just living in it. The top 3 are all Ayush.
Dr. Kant and Dr. Ganesh, we request you to turn on cams.
Yeah.
Answer is erlotinib, EGFR tyrosine kinase inhibitor. Yes, next question. So answer for this question is obstructive sleep apnea risk. So all these questions are taken from the first 600 pages of Bailey and Love 28th edition. Yes, next. Very good. The answer is post-operative complications based on grade is correct answer. Clavy and Dindo classification. Yes. Next. Question from Bailey and Love. The answer is small bowel, colon, and stomach is last according to Bailey. Though it is wrong, this is from Bailey and Low. It is stomach is last as per Bailey and Low. Yes, next question. Answer is midbrain dysfunction. You have case paralysis in midbrain. You cannot move beyond the eyeball. Only one answered correctly. Yes.
So after 10 questions, we still have Dr. Ayush Badani leading it, followed by Dr. Ayush Vyas, then followed by Dr. Sachin, and then the fourth position goes to Dr. Ayush Gupta. Dr. Kant is not very far behind. He's only behind by about, what, 63 marks. So still 5 more questions to go. It's your chance to come onto the top of the leaderboard in the top 4 for this next round.
Very good. All of you answered correctly. Answer is diffuse axonal injury. Usually CT scan has no good finding. MRI is the investigation. Yes, next. On has come up. Yes. As per Bailey and Love, stage 3 is. Yes, most of them answered correctly. Answer is ICU management. Next. Answer is yellow. Second priority is given for degloving injuries. Yes. Next question.
Sir, I think because answer was yellow, but green was the answer option available in yellow.
Yeah, most probably the people would have marked it wrongly because of the seeing the color, but answer is yellow. Yeah, next. Yeah, only 2 more questions. The answer is tertiary blast. It's a new question from 28th edition. Yes, last question.
So just before the last question, Dr. Uh, Ayush Badani, Dr. Ayush Vyas, Dr. Sachin, and Dr. Ayush Gupta are on the top in the top four. Dr. Kant, you still have an option. You still have the chance to break the barrier and enter the top four for your selection in the next round. The last question.
Thank you. Answer is epistaxis, bradycardia, nausea, and syncope are the clinical features of inferior rectus entrapment. Yes, final score.
So after the first round, we have Dr. Sachin at the third position, Dr. Ayush at the second position, and Dr. Ayush Badani at the first position.
Very good. Congrats. Who is on fourth position, Ravi?
Yeah, Dr. Dr. Ayush is in the fourth position. So Dr. Ayush Vyas is on the second position, Ayush Badani in the first position, Dr. Sachin in the third position, and we have Dr. Ayush Gupta in the fourth position. So the fourth finalists for us in that order are Dr. Ayush Badani, Dr. Ayush Vyas, Dr. Sachin, and Dr. Ayush Gupta. Very, very congratulations for
Congrats to all
entering the second round.
toppers. So we'll go on for the next round. So those who have not cracked, all of you did very well. So extraordinary answering by most of you. So let us go on to the last round. It will be a Zoom session round. We'll be having 4 members for this round, A, B, C, D. So only those who are going to answer, you should make them as co-host, Ravi. Others can be muted. A, B, C, D, you select overall A, B, C, D.
So I'm just writing the numbers across their names, sir.
Yes, 1, Dr. Ayush Badani will be A. Yes, Dr. Ayush is 2. Ayush Vyas.
Yeah.
Sachin is 3 now. Dr. Sachin.
Yeah, Dr. Sachin is 3.
Yes.
And Dr. Ayush Gupta is in the
4th
fourth position.
Yeah, they 4 will be attending the session, and you can mute as well as stop the videos of others.
Yeah.
So they 4 will be live. So when that is actually the question round is very simple. There will be no passing by like we do in an open quiz. In the classroom quizzes, we can have one person not answering, we can pass to the next person who can answer this, but it is not possible here. So if you are going to answer it correctly, we'll be giving you 10 marks. If you're not going to answer it completely, or if you're answering partially, we'll give you 5 marks. And if you're not answering, there will be 0 mark, and we will tell the answer. And we'll go on to the second person. Second question will be there. So like this, we have 18 rounds. I am going to start the first round with the GIT. Okay.
So, sir, just one doubt about scoring.
Yes.
Yeah. Scoring every question to every participant is 10 marks, right, sir?
Yeah. Every question is 10 marks.
Okay.
So only the participant, we will be telling A, B, C like that, they should answer the question.
Okay.
Sir, any negative marking?
No negative marking. It's like you are going to answer it orally. There is no marking. You should tell the answer.
And sir, any use of the phone app notes on live based?
No, nothing. You can see the screen and answer. Like it will be like a Viva.
Okay, sir.
Right, sir. So you will be telling after every question how many marks for it. If are there any half marks available?
I will be telling. I will be telling the marks. So shall I share my screen?
Yes, sir. Sure.
One second.
So will there be any time limit to answer the question?
No, just 15 seconds for each candidate. Just 15 seconds. So you can tell if they are not answering in 15 seconds, I will tell the answer and go to the next question. That's all. You have to tell. Either Ravi or Karthik should tell me what is the time for each. Okay.
Sure, sir. I'm making a note.
Yeah. So I'm starting the session. Are you seeing my screen?
Yes.
Yes. So shall I start? So number 1, Dr. Ayush. You can tell who should answer, Ravi.
Yeah. The first question is to Dr. Ayush.
So this is a
Dr. Ayush Badani.
Ayush Badani, please tell me what is A, what is B, what is C from the image.
A is Stemmer's hernia, B is Peterson's hernia. C, I'm not sure, sir.
See, there is a name for that hernia. It's a jejunal area. There is a name for the hernia. Can you tell the name? So one is, A is Stammer's hernia behind the mesocolon. B is behind the limb, Peterson. C is Gruber hernia. It is updated in new edition, Bailey. So C is Gruber hernia. You can give 5 marks for Ayush Badani. So next candidate, B. Who is next? B, Ravi?
Dr. Ayush Vyas.
Dr. Ayush Vyas, can you tell me the answer for this B? Name the procedure illustrated here.
So this is a type 2nd, Billroth 2nd.
No, there is you can see in the picture, there is a small ulcer there. There's a clue.
Okay, fourth gastric fourth ulcer. This is distal Sandy's.
Very good. That's very good. That's the Sandy's procedure. What are the other procedures? Type 4.
There are 3 procedures we can done. It's Sandy's, a subtotal gastrectomy, and leaving the ulcer proximally, and distal gastrectomy can be done.
What is the name?
Sir, actually,
there are 2 other names, no?
Yes, sir. Yes, sir. I know 3 of them, but
yeah, you can give 5 marks for him. This is Sandy's procedure. There are 2 more procedures: Killing, Madliner, and Pouchet procedure. So this is Sandy's for type 4 ulcer. Okay. So very good, Ayush. That's correct. So we'll go 5 marks for Ayush Vyas. Third question for next. So what is this procedure? Who is third? Sachin?
Dr. Sachin.
Yes. Yeah. Yes, sir.
What is this procedure shown here? What is the name of this procedure?
Sir, I'm looking at the diagram.
Yeah, please watch it.
Sir, this is transposition of jejunal segment.
Yes. Between the esophagus and stomach. What is the name?
Yes.
There is a name for this procedure.
Esophagojejunos.
No, there is a name. Actually, all the procedures we are telling have names for this first round. You don't know? Yeah, this is Merendino procedure. Merendino procedure, which is jejunal interposition between the esophagus and stomach. So this is mainly done for peptic strictures, and for early tumors of the lower end, we do this Merendino procedure. No, this is this is usually a question commonly asked for SG aspirants, surgical gastro aspirants. So no problem, Sachin. You will pick up in the next round. So answer for the fourth person. Who is fourth? Ayush? Yeah. Name the trials I have told here. What is the procedure shown here? What is this procedure?
So this is some endoscopic stapling, if I can.
No, what is the name of this procedure? There is a procedure being done here. It's an endoscopy procedure only. What is that procedure? I have actually removed the answer just now, if you have watched it closely. It's a very interesting procedure done.
No idea, sir. If I have to make a guess, then I'll make a guess based on the endoscopic procedure for some hiatus hernia.
Yeah,
but I'm not sure.
Yeah, you are correct. For hiatus hernia, what is the name? What is this procedure? What is the procedure you put a stapler like this?
I'm not sure, sir.
Okay, this is esophyx or a transoral incisionless fundoplication procedure. So all these pictures are taken from new Shackelford. So latest edition Shackelford. This is esophyx or transoral incisionless fundoplication. Okay. So A and B had 5 marks. C and D had no marks, Ravi. Shall I go on to the second round?
Sir, Sachin's marks you didn't mention.
A, B, 5, 5.
Yeah.
A, B, 5, 5, yes, sir.
C, D, 0, 0.
Okay, done.
Sir, can you put your PPT in slideshow mode?
If I put the slideshow, I'm unable to see them. Is it okay now?
Yes, sir. We are able to.
Okay, that's good. That's good. Then I'll go on because I could not see the student who is answering. That's why he was putting like that. Yeah. So now for A, you should tell who is going to answer, Ravi.
is for Dr. Ayush Badani.
Ayush Badani, please answer this question. R-like procedure means for which it is done. What is it? Ayush Badani is not visible.
Sir, it is done for rectal prolapse, that
Yes.
I remember. Fixing to sacral promontory, sir. Indicate details, I'm not sure, but mesh is used, and rectopexy, it is like a rectopexy for rectal prolapse in which a mesh is used, sir.
And where will you fix the mesh?
So sacral promontory.
No, on the rectum.
Anteriorly.
No, you can give 5 marks for Ayush Badani. It is a lateral rectopexy.
Lateral.
So lateral rectopexy. So this is a lateral rectopexy. There is a D-more procedure called as ventral rectopexy. D-more is ventral. This is lateral rectopexy. So this is from Shackelford. So all the gastro questions are from Shackelford. So 5 marks can be given. Lateral mesh rectopexy or like procedure. So next B. What is the procedure shown here? Next Ayush.
Dr.
Vyas.
Ayush Vyas.
Ayush Vyas. You keep telling the student's name. Okay. Then
Sure,
only.
sir.
What is this procedure shown here? You can see a procedure done at anus. Multiple incisions are being done. It's a named procedure. Picture from Shackelford only. 3 incisions are made. Yes. Ayush Vyas?
Oh, sir. I don't
know. So this is modified Hanley's procedure for horseshoe abscess.
Okay.
Modified Hanley's for horseshoe abscess. Yes. Okay.
Diagram.
Yeah, the pictures all from Shackelford only. All images are from Shackelford. So for C, Sachin.
Yes,
so
sir.
this is a picture showing you J pouch, W pouch, S pouch. What is the indication of S pouch? Sachin? When will you go for S pouch instead of J pouch? Yes. Any idea when from J pouch, one indication I'll go for S pouch. What is that's indication? This is a very commonly asked SS question. No idea?
Oh, sir.
Yes, I'll tell you. This J pouch is not coming to the anus. It should reach the anus for a ileal pouch, anal anastomosis. No, if it is not coming to anus, we'll go for an S pouch. S pouch will help to reach the anus. And the one disadvantage of S pouch is we have to do manual reduction. It will not properly drain. They have to put a tube and drain very frequently. So that is a disadvantage of this C. Okay. So last question of this round. So
Dr. Ayush Gupta.
Ayush Gupta, name the cancer rectum operation going on here. This is another picture from.
Yes, sir. Sir, this is most likely the TAMIS procedure, the transanal minimal invasive surgery.
Very good, very good. That's correct. That's correct. I'll give you 5 marks for that. This is transanal mesorectal excision. Another 5 mark is what can be injured in men in this procedure?
Sir, in this procedure, sir, the we can the mostly the anteriorly the Denon-Villiers fascia and the we can injure the we can create a rectovaginal fistula in the females and we can enter the anterior things in the males.
Which structure is specifically injured in men?
In men, sir, in men, sir, seminal vesicles or prostate.
There is a specific injury which is very commonly happening in this. So this procedure was not done commonly. Transanal total rectal excision. What is present anteriorly?
Sir, maybe due to the hypogastric plexus, it may lead to the retrograde ejaculation later on.
No, only urethral injury will be there. There will be urethral injury. So you can give 5 marks for him. 5 marks for this question. So there is the only problem of this procedure is in men there may be high incidence of urethral injury. So urethra will be injured. So there is 5 marks you can give for Ayush Gupta.
I remember now. That's why we keep a catheter in place.
Yes.
This.
Very commonly asked question for this transanal total mesorectal excision. Yes, that's good. So have you marked the
yes, sir.
Correctly?
Yes, sir. I mentioned in the chart.
Yeah. I'll go to the third round now. Third round is hepatobiliary and pancreatic system. We have to start with Ayush. So this is a very easy question. I think those who are preparing for SS exams will know the answer. What is this procedure shown here? Ayush.
Dr. Ayush Bhadani.
Yeah, you should tell who is going to answer, Ravi, because many
Yes.
rounds are going to happen. Many faculties will come. They don't know
Yes.
who will answer. You should tell.
Yes.
Yes. Because they will just put the question and they will wait.
So this is done for Wilkie syndrome. Median arcuate ligament release for.
You just see this. The first picture is a problem. Second picture is
Yes,
a
sir.
removed problem. So what is the diagnosis? This is a very interesting procedure. Very commonly asked AIMS question. Every year in AIMS exam, this question comes.
Sir, RAMS procedure?
No. That is a very important thing. I'll give one clue. If I give the clue, I'll give you 5 marks only. Celiac artery is resected. Can you see there?
Yes, sir.
Celiac artery is resected, ensuring the collateral from inferior pancreatic duodenal is going well to the hepatic artery. What is this procedure? No? This is modified Appleby procedure for cancer in the pancreas infiltrating celiac axis. So modified Appleby procedure. This is modified Appleby procedure. Okay. Go on to the next procedure. So
Dr. Ayush Vyas.
Ayush Vyas, what is this procedure shown below? This is a question, very simple question actually. This question is the most easiest question from Bayesian law.
1 second. This is cholangiography done by ERCP, and we saw.
No, not by ERCP. There is a T. I will give a clue. There is a T tube. There is a stone. Now tell me the answer.
Okay, sir. This is a T tube. This is resection after. If retained stone are present, we can remove it by this. It is.
Yeah, what is the name of that technique?
Yes, sir. Sir, I know, but
it's not second you now. That is a quiz program. The easy question will not come to the mind.
This is
yeah, no problem. I should don't get confused. This is a T-tube removal stone Burgin technique. This is Burgin technique. Yeah, from Bayesian law. This is from Bayesian law. So,
I know just
B. So next question. See, this is another easy question. Sachin, this is the easiest question.
Any marks for Dr. Ayush?
No marks. No marks.
Okay.
Ayush Badani, Ayush Vyas, both of them not given any marks. Sachin, this is an easy question. Can you tell me what procedure illustrated here? This is another question from Bayesian law only. Sachin, can you understand the procedure?
Yes,
yeah.
Sir. So this is so this is hemihepatectomy.
Yeah, what there is a special thing going on in this procedure. First step, second step, like that, they're given in multiple steps. No, so what is being done? Usually others will be knowing the answer for the others question. And the same question comes for you, you will be blinking. That's the problem in this quiz program. Most of you will be knowing the answers. But I think Sachin is able to answer. We will be thinking about other answers, but it's difficult for him. Leave it, Sachin. This is ALPS procedure. The moment you see this, you should strike. See, first step in ALPS procedure is we ligate the portal vein alone, and we partition the liver. Second step, we remove this for a patient who are having very less FLR. We do this ALPS procedure. Okay, this is C. And I think this round is an easy round. I felt you all will be answering, but none of you are answering this round. So next round is very difficult. None of you will answer any question. So this is the easiest question again. What is the diagnosis? Dr. Ayush Gupta.
Dr. Ayush Gupta.
What's the diagnosis? The question is not the diagnosis. I'm going to ask you one. What is the diagnosis from this picture? Ayush Gupta?
Yes, sir.
Is it?
Sir, most likely it is looking like pancreatitis image with the with the fluid collection. Pancreatic. Look like might be a pseudocyst of the pancreas.
There is air and all, no? So what do you give this?
So the necrotizing pancreatitis could be there.
Yes, this is a necrotizing pancreatitis. The question for you is, what is the trial according to which it is treated now? There is a new trial.
According to of necrotizing pancreatitis.
Yes, necrotizing pancreatitis is treated by one trial now. It's a step-up approach trial. What is it?
No idea.
Once upon a time, for a pancreatic necrosis, we do laparotomy and remove the necrosis. Now we do step-up approach. What is the name of that trial? That is Panther trial, Penguin trial. 2 trials are there. According to those trials, we have modified the treatment of pancreatic necrosis to step-up approach. So no mark for anyone in this round, Bablu. Yes.
Noted, sir. Noted.
Yes. Final round from my side. It's a transplant from Sabiston. I am not discussing detail, but I put some rare facts directly from Sabiston 21st edition. So, Ayush, in the process of xenograft transplant from pigs to human, transplant concordance is predominantly determined by the expression of which enzyme? Can you tell me? If you have read transplant only, you can answer these questions. It's really tough questions. Actually, I searched and found out all these 4 questions. There is an enzyme that based on that enzyme only we will say this transplant concordance is predominantly determined in case of xenografts from pigs to human. Yes?
Hypoxia, some hypoxia related.
One enzyme, there is one enzyme. So there are drugs now available to stop that enzyme being secreted from the donor grafts. This is a paragraph from Sabiston. When you go and read Sabiston about this xenograft, you'll see this. This is really difficult. If you have already not read, you cannot answer. This answer is alpha glucosidase. Alpha galactosyl transferase. So this is the answer for this question. So this enzyme, you just go through this paragraph, you'll understand the importance of this enzyme. So we'll go to the B. Pretext classification is used for tumors before deciding on management. Which tumors?
Dr. Ayush.
Yes. Ayush.
Yes.
So accordingly, 10% of the cases of these tumors will go for transplant. Pretext classification is used for which tumor?
Hepatoblastoma.
Very good, Ayush. That's correct. It is for hepatoblastoma. So pretext is a classification used for hepatoblastoma. 50% of the tumors are operable. 10% will be unresectable. So we can take them for transplant. You can give 10 marks for Ayush Vyas. That's correct. So another question, C for Sachin, anti-CD52 humanized monoclonal antibody. What is it? The drug used
Alemtuzumab.
Very good. So you can give 10 marks for Sachin also. It's alemtuzumab. 10 marks for Sachin. Last question to drug with unique mechanism of acting that results in sequestration of lymphocytes within the lymph nodes, thereby preventing them from participating in allograft rejection. Which drug? Any idea?
Yes, sir. Just a second. The proliferation को कम करता है MMF calcium.
It's a new
Sir, calcineurin inhibitors.
No, not that. Not the regular drugs. It's not a regular drug.
Some new drug. No idea.
This is fingolimod. So new update from the Sabiston 21st edition, fingolimod. So Dr. Sachin and Dr. Ayush Vyas 10 marks in this round. So please tell me the score of A, B, C, D at the end, Pablo.
So Dr. Ayush Badoni, 10 marks after round 4. Dr. Ayush Vyas, 15 marks after round 4. Dr. Sachin, 10 marks after round 4. Dr. Ayush Gupta, 5 marks.
Very good. Okay, Pablo. So there are so many rounds yet to come. 18 rounds we have totally. Different faculties are going to come. So don't lose the hope. Be concentrating the questions. Definitely, you are going to get more easier questions for different. Actually, the original quiz can be understood only when we pass the question. When somebody is not answering, when it goes to other persons, it will be good. But here we cannot pass because meanwhile you can find out the answer from the mobile. Therefore, we are not passing. Otherwise, we'll be usually passing the questions. So anyhow, at the end of 4 rounds, my job is over.
Just a word, just
yes,
one thing. With regard to the question that you asked on the Appleby procedure,
yes.
I think Dr. Ayush Badani gave the answer as ramps.
Yes.
It's partially true in the sense that ramps is the first component of the Appleby procedure, of the modified Appleby procedure.
So you like to give him 5 marks?
5 marks, yeah, because he has answered half, I felt. Because some,
please give 5 marks for Ayush Badani. Yeah, please give 5 marks for Ayush Badani, Pablo. Add 5
Noted.
marks.
Noted, sir.
Yes, that's good. Okay, Balaji sir, you can start your session, and next Venkatesh sir, you can carry on.
So
Tough questions,
this
sir.
is
Scoreboard.
so this is the scoreboard after the first 4 rounds.
Superb.
Yeah.
So now the fourth round. Who is starting, Venkatesh sir or Balaji sir? Who is starting there next?
I am due. You have to make me a co-host, Teja, Ravi Teja.
Make screen sharing with Balaji Ramani sir. So Balaji sir is going to do 4 rounds. Round 5 on breast, round 6 on thyroid, round 7 on endocrine, and round 8 on miscellaneous. Okay. So there are 4 rounds from Dr. Balaji sir. After that, you have urology rounds. Yes.
Just a second. Let me. Yeah, can you see the slide on screen here, everybody?
Yes, sir.
Okay. So welcome to the fifth round. It's an exciting quiz. All the questions are pretty. Some of them are easy, but some of them are quite complex as well. And many of you have done very well. It's indeed exciting to see such young talent coming up. And welcome all to the DNA surgery residency quiz from DocTutorials and RRM. Let's go on to the next quiz pattern. Basically, already what has been described. 1 question to each candidate, no passing, no negative marks, 10 marks with 5 marks being reserved for partial answers. Our decision is final on what is going to be there. And 15 to 20 seconds we'll give before and after I say start, you can start with the answers. So the round 5 is going to be one of the most common topics that comes up in your NEET and INSS examinations. It's on breast surgery. So this is to Dr. Ayush Badoni, right?
Yes, Dr. Ayush Badani.
Yeah. So unlike what Dr. Rajamendran has said, my questions are almost entirely clinical based questions. So it will be a little more tough, but I think, most of you should be able to get the answers. Let's see. So this was a 55-year-old gentleman who presented with a left breast lump. Biopsy revealed to be a carcinoma of the left breast, and he underwent surgery as the picture which is shown here. Have a look at the picture. I want the exact procedure which is done here. Have a careful look at the picture which is done. And that is the first question. And the second question is, in addition to, I'm not talking about adjuvant therapy here. What additional tests do you do other than the routine tests in this particular patient, considering the clinical history? These are the 2 questions for you, Dr. Ayush Badoni. So you can start now.
This looks like to me as a sentinel lymph node biopsy done first, followed by a modified radical mastectomy. Additional test,
so
which I
that
would.
is perfectly true. That is 5 marks for you already. You got it. This is indeed a left MRM with sentinel lymph node biopsy. You have beautifully identified the blue nodes here. Yes. What additional test would you advise considering the clinical history?
So first, as it's a male breast carcinoma, then one thing is BRCA mutation testing would be there.
So you will be ordering for hereditary breast cancer testing, considering it's a male breast cancer. Male breast cancer diagnosed at any age requires BRCA testing. So absolutely right. So Dr. Ayush, you got full 10 marks correct. I think people are finding this easy maybe because it's clinical. But anyway, it's a good answer. So you get 10 marks, Dr. Ayush. Moving on to the second person. This is Dr. Ayush whom?
Vyas.
That is Dr. Ayush Vyas. Okay. So question for you, Dr. Vyas. Are you ready? Yeah, so 65-year-old lady, she has undergone this procedure here.
Dr. Ayush, you are on mute. Yeah.
My big screen, Dr. Venkatesh sir is live, but I can't see questions.
You're not able to see the questions?
No, sir. Sir, it's your, I can see your.
I could see the question. I think there is second question I'm seeing.
Come again, you can just.
How can I?
Can you see now, Dr. Vyas?
Sir, I can't see question.
Just check the device, Vyas. It's
device, sir. I can see large image of yours and a small image of yours also. Both images are of yours.
So, Dr. Ayush, please check if you have pinned the video of some faculty to the screen, if that is visible on your screen, pinned video. If that is pinned, you can just remove it so that you can see the screen shared as well, because all of us otherwise are able to see the screen share.
Let's see.
So can you check can you have you joined through a mobile, sir?
No, sir. I am joining through iPad.
Okay. Is
Can
there
you
any left or
speak
right
for
scroll
exit?
option you can see?
No, sir. There is no explanation. No. Yeah. But right in my right side, all of are visible, but question is not visible.
You can re-log in, Ayush. There is no problem. You can just re-log in.
Okay,
By
sir.
the time you'll finish the third person.
Yeah, we
You
can
just sign
pass
out
this
and
question
re-log.
to Dr. Sachin, and in
Yeah.
the meantime, you can relog in.
Yeah. So Dr.
Yes,
Sachin,
sir. So this looks a latissimus dorsi flap.
see, look at the procedure carefully, Dr. Sachin. See, this is a patient seen from the anterior view in a craniocaudal direction. This is the first picture, which you can see in the craniocaudal direction. This is the craniocaudal direction. And then the second picture is from the side where you're only seeing the axilla. Okay, this is on the lateral aspect of the breast that the incision is made. So the questions are two here. One is, what is the flap which has been done for this particular patient? And what type of oncoplasty is this?
Pectoralis major myocutaneous flap.
Okay, and what about the type of oncoplasty?
That I have no idea, sir. Oncoplasty.
Okay, both are not correct. So this is what we call as the LICAP flap, the lateral intercostal artery perforator flaps, which can be done with or without the skin paddle here. So we make an incision along the lateral border of the breast in the axilla, and then we use the flap. This is given in Bailey and Sebastian, if I'm not wrong, and it's commonly used in breast reconstruction. It is a type 2 oncoplasty where you're doing a volume replacement. It's not just a volume displacement, you're doing a volume replacement here. So this is a type 2 oncoplasty that we have here. So no marks for Dr. Sachin for this. Is Dr. Vyas back online?
Dr. Vyas is yet to join, sir. We can
Go on
take
to
the
the
next
board.
question to Dr. Ayush Gupta.
Dr. Ayush Gupta, you are ready?
Yes.
Okay, so you can see another picture here. This is a 75-year-old lady who underwent, breast cancer surgery. And what is the exact procedure which is being done here? I want you to be very exact here. And what is the principle behind this technique which is used here?
So it looks like some use of some radionucleotide dye and utilizing the with the gamma camera vision and taking the identifying the biopsy of the axial lymph node or the mass. Looks like some radionucleotide procedure for the.
And what about the second question? What is the principle used here?
So, the principle used. So the principle would be the selective absorption and of the dye and visualizing with the specialized vision. It takes up the dye and.
Instrument which will be used to visualize it?
Yes, sir.
What is the instrument that will be used to visualize this?
So the tracer, uh,
What is the instrument that will be used for visualization? There is a particular name.
not able to recall, sir, as of now.
Okay, see, you are only right with regard to the procedure, meaning a sentinel lymph node biopsy is being done for the axilla, but I cannot give it to you because I have mentioned clearly here this has to be an exact answer. This is an ICG SLNB. Indocyanine grade. See, when you are using your radionucleotide dyes, you will not see any visual impact. You will see only the count. You'll be using the gamma camera probe and you'll be seeing the count on the reader, and that is where you'll be measuring. You cannot visually find out the node. Visually, you will just go to the node and you will keep your probe there and find out the counts. Based on the counts and the 10% rule is how you will take out in a radionucleotide based SLNB. What is being done here is a visual technique where we are using ICG injection intradermal or intratumoral, and after that you are identifying the node. So this is an ICG SLNB technique, and the principle which is used is near infrared imaging. NIR imaging is what is being used here. You can see it's a black and white image mode. So this is your NIR imaging. You also have hybrid modes which are available, but this is your NIR mode which is being used, near infrared imaging, which is being used for this particular patient. So no marks to you, I'm sorry, Dr. Ayush Gupta, for this particular question. Right. So can I
Dr.
go?
Vyas has joined back, sir. Dr. Vyas,
Yeah,
are you
Dr.
able to
Vyas, if
see
you
the
can please
question
the
screen now?
slides here.
Yes, sir. Yes, sir.
Yeah.
Okay, so I'm going on to the question for you. So this is a 52-year-old lady who presented with this condition. So your questions are, one is the exact diagnosis and the diagnostic criteria. And second question is, what surgery is going to be contraindicated for this lady?
This is a inflammatory breast cancer.
Okay, and what is the exact diagnostic criteria?
Diagnostic criteria. Sir, more than 1/3 of breast should
Okay,
be.
so I will accept that answer. That is 5 marks to you. So this is inflammatory breast cancer indeed, where the erythema and the induration extend for more than 1/3 of the surface of the breast. So this is correct. So answer A is correct. What about what surgery is contraindicated for this lady?
Breast conservation surgery.
Yes, you got it right. I think you took a guess, but it was a lucky guess for you.
No, but I think procedure, named surgery, but breast conservation surgery.
Okay, so breast conservation surgery is indeed contraindicated for this particular patient. See, there are very few contraindications in today's world for the breast conservation surgery. Even a skin involvement like T4B disease we have in other cases, not T4D, T4B disease if we have, we can still go ahead with the breast conservation in today's world. But inflammatory breast cancer is an absolute contraindication for doing a breast conservation surgery. We have to do a modified radical mastectomy. So you got both right. So both the answers are correct. Ravi, can you just tell us the score shortly?
बताओ
Yes, sir.
बाद में
So, so we in this round we have 10 marks given to Dr. Ayush Badani, 10 marks given to Dr. Ayush Vyas, 0 each for Dr. Sachin and Dr. Ayush Gupta, and overall scores stand at 25 each for Dr. Ayush Badani and Dr. Ayush Vyas, and Dr. Sachin is on 10 and Dr. Ayush Gupta on 5.
Okay, so buck up both of you, Dr. Sachin and Dr. Vyas, and we can go on to the next round here. Okay. Questions are all clinical based. So this is on round 6 on thyroid and endocrine based surgery, mostly on thyroid. I think you should be able to get most of this. So this is for Dr. Ayush Badani, correct?
Yes.
Okay. So this is a 35-year-old lady with a right solitary nodule of the thyroid measuring 3 into 2 centimeter. This is the picture that is marked on the operation table. So I want you to name the planned procedure for this patient. And the second option is, what is the accepted size of the nodule for the procedure if the FNAC is proven to be a classical papillary thyroid carcinoma? Dr. Badani, what is the planned procedure here?
This looks like minimal invasive surgery for the thyroid, mostly through the chest approach, anterior chest wall approach.
Okay.
And the accepted size of nodule, if it's a classical PTC, would be 2 centimeters. Sir.
I accept that answer. It can extend up to 3 centimeters according to some
2.
studies, but many of them mention the criteria cutoff as 3 centimeters. So, I mean, as 2 centimeters. So I will accept these answers. Both the answers are correct. So this is indeed a minimally invasive approach, a laparoscopic or endoscopic thyroidectomy, as we call it, through an infraclavicular approach. There are multiple approaches. There is a Totiva approach. There is a robotic approach. Multiple minimally invasive are there. So this is an endoscopic thyroidectomy approach, where the size cutoff for a papillary thyroid carcinoma is usually taken to be 2 centimeters. Some studies also mention up to 3 centimeters. Great answering. Second to Dr.
Vyas.
Dr. Ayush Vyas. Yes, are you ready? Are you able to see the picture on the screen? Dr.
Vyas,
Vyas,
you are on mute.
Yes, sir. Sorry.
Yeah. So this is again a
Yes, sir, I can.
question for you. Identify the marked area in the picture. And the second part is, name the boundaries of the other similar important area in relation to thyroid surgery.
So this is a Bayes triangle.
Very good. So what are the boundaries of the Bayes triangle?
Sir, inferiorly, it is a superior thyroid artery, and in posteriorly, this is a carotid artery, and superior laryngeal nerve.
There in front of you, it is infromedial is by the rectal laryngeal nerve, posteriorly by the common carotid, and the
Common
inferior
carotid.
is the superior border. That is going to be the boundaries. But your second question is not that boundaries. The second question is what is the other similar important area in relation to thyroid surgery and what are the boundaries? You get 5 marks already. Do you know of any other triangle in relation to thyroid surgery? That is the second question for you. Dr. Vyas, you're online?
Yes, sir. Yes, I'm online, but I don't remember that.
Okay, so 5 marks to Dr. Vyas for this question. So he named the Bear's triangle correctly, and the landmarks are as mentioned. Now the other triangle is the Joel's triangle, which is present in the superior border. That is for identification of the external branch of the superior laryngeal nerve. So laterally, you will have the superior pole of the thyroid and the superior thyroid vessels. Medially, it will be the midline that will form the boundary, and superiorly will be the attachment of the strap muscles to the thyroid cartilage. The floor will be formed by the cricothyroid muscle, and that muscle will be supplied by the external branch of the superior laryngeal nerve. So the two important nerves that we try and preserve. See, previously we used to be worried only about the recurrent laryngeal nerve. We realized more and more that the superior laryngeal nerve is also important. So the Joel's triangle will help us to identify. That is a good landmark to identify the superior laryngeal nerve, and the Cernia classification is again something that can help you identify based on the type of configuration of where it crosses. So 5 marks to Dr. Vyas for this particular question. Going on to the next one. This is to Dr. Sachin. Are you ready, Dr. Sachin?
Yes, sir.
Yes. So this is a 23-year-old gentleman who underwent surgery. This is the surgical specimen picture that is depicted here. Now I want you to identify the exact syndrome, the common mutation, and the exon and codon. That is the first part of your question. The second part is what are the risk categories? Is the picture clear? Are you able to see what is written there and all?
Sir, in the right top, I'm unable to read.
See, this is a right modified radical neck dissection specimen. What we have here is a total thyroid plus bilateral level 6 neck dissection. That is what you can see here. And the parathyroids, 3.5 parathyroids, 1, 2, 3, and 4, which are removed. That is the 3.5 parathyroids. And you have the right and the left adrenalectomy, which has been done. That is the procedure which has been carried out here.
Yes, sir. Sir, this is men syndrome and men 2B.
Okay.
Hello.
Yeah, go ahead.
Yes, sir. This is men 2B, and the mutation is in red gene with
I want the codon and the exon as well.
sir, 918. 918.
918. Okay, fine. I'll take that. What else? Exon is? You're not sure. Okay, forget that. Go on to the risk categories associated with this.
Sir, chromosome is 10q. Okay. What?
No, I don't need the chromosome. I just want the risk categories. The codon and the exon will tell us all the information. What are the risk categories that are associated with the Men's syndrome?
Sir, highest risk.
Okay. Yeah, I want all the risk categories. So if you're saying it is meant to be, then yes, you are right. M918T will have the highest risk category assigned to it. What are the other risks which are there?
883.
Okay.
Only two I know about two.
Okay. I will give you 5 marks for this question, Dr. Sachin, but you didn't actually get the syndrome right. It is actually MEN2A or the MEN2 syndrome that we have here. See, I told you very clearly that a 3.5 gland parathyroidectomy has been done. Parathyroids are not involved in your MEN2B syndrome.
Yes, sir.
So this is a MEN2A syndrome that we have here. It's not MEN2B, it's a MEN2A syndrome. So you will have the medullary thyroid carcinoma, and usually you will have around the 30 to 40% incidence of parathyroid adenomas, and you will have sort of like, adrenal tumors, all that will be there. In men 2B or men 3, as we call it, there you will have the involvement of the marfanoid habitus, the mucosal neuromas of the tongue and all that. So this is a patient who has a men 2A syndrome. The common exon and the exon mutation is going to be your exon 11 with your codon 634 mutation. And the risk categories, as you mentioned, the highest is for men 3 with M9180. Then you have the high risk, which is codon 634 and A883F. All the other mutations will be coming under the intermediate ATA risk category. Okay, so you can take 5 marks for this question, Dr. Sachin. Now going on to Dr. Ayush.
Dr. Gupta.
Dr. Ayush Gupta. Yeah. So Dr. Ayush Gupta, can you see the screen for this one?
Yes, yes, sir.
Yeah. So this is a 35-year-old lady with a papillary carcinoma of the right lobe of the thyroid who was undergoing surgery. Intraoperatively, this picture was taken. Now, what do you see in this picture? What is this technique? What are the structures? That is the first question. The second question is, if no IV drug was given before this picture, then what is the principle that is used for imaging?
Looks like a thyroid scan, sir.
I'm saying it's intraoperative picture. Look at the question carefully.
Sir, I'm not sure about the technique, but one of the dominant nodule, one of the dominant part can be seen on the left lobe of the thyroid, probably.
Okay. Right. What about the principle?
Principle, not sure about this technique, sir.
Just think a little before you answer, Dr. Ayush Gupta. Do we do an intraoperative thyroid scan?
Yes, sir. We do.
Intraoperatively, do we do the iodine scan?
No, sir.
We're talking
I
about an
don't.
intraoperative scan to look at the thyroid. I'm telling you again, this is an intraoperative picture. This is not a post-op picture.
Sir, I'm not sure about the picture. I know we measured the intraoperative parathyroid hormone. Never seen this picture, sir.
Okay, this is just a regular ICG camera and your near infrared spectrum, same thing we are using here again. So the structures that you can see are one side, we are seeing the parathyroid, superior and the inferior parathyroid are being seen here using the same technique that we use in sentinel lymph node. Only thing in the sentinel lymph node, always you have to give the dye before you visualize. Now this is, if you keep it at the highest sensitivity settings, you can find out the parathyroids just by shining your infrared light in that area, you can visualize it. And it'll show the activity as well. Now, this principle is known as autofluorescence. Okay, that is why I mentioned here, no IV drug is given. That is the clue for you. IV drug usually will be ICG, which will be given. So indocyanine green can be used in cases you are still not able to do by autofluorescence. You can give IV indocyanine green and then you can do. But in this particular patient, it was readily visible by keeping it at the highest sensitivity mode, and we could identify the parathyroids on both the sides. So we did identify the parathyroid, so there was no need to go for ICG. So the principle is again autofluorescence. Parathyroids have autofluorescence. Nodes do not have autofluorescence. You always have to give and pick up the nodes. Parathyroids can be identified. It's a very, very useful adjunct, especially in patients with thyroid and you're not sure whether it's a lymph node or a parathyroid. Those kind of cases, autofluorescence will help you find out whether it's a lymph node or a parathyroid. So I'm sorry, I cannot give you any marks for that question, Dr. Gupta. So yeah, can we have the marks at the end of this round?
So we have Dr. Gupta at 5, Dr. Sachin at 15, Dr. Vyas at 30, and Dr. Bhadani at 35.
Okay, so buck up, guys. There's still, we are near the sort of like, midway mark. Buck up all the people who are there. Dr. Ayush Bhadani, keep going. Don't give up your lead. Yeah, so the next round, round 7, our Dhoni heavy hitter round. So let's see if we get some heavy hits in this round from all of you. This is on head and neck oncology. So all the questions are clinical from my side, as I said initially. So Dr. Ayush Bhadani, here is the question for you. Are you ready? Can you see the picture?
Yes, sir. Yes, sir.
Okay, so this was a 65-year-old lady who came with complaints of a swelling in the palate, which had been biopsied. This is the preoperative image just at the start of surgery. if I zoom, you can see that this is actually the tooth that we have, and this is the tumor area.
Hard palate looks like
The hard palate area, correct? So that is the tumor. So now the question for you is, what is the proposed procedure for this patient? What do you think will be the proposed procedure that is being done for this patient?
So I'd like to go with a maxillectomy with a bilateral modified neck dissection with a right-sided modified neck dissection. Also depending on the end stage is what I would like
I
to
just
support.
said the procedure for the primary. The secondary is fine. Don't overshoot your answers, because
Sorry, sir.
remember that maxillectomy is the correct answer.
Yes, sir.
Fine. Okay. So this patient, you actually need further information. What information would you like to have if you want to qualify the answer further?
So I'd like to know the nodal stage status, the metastasis.
Forget the end stage. I'm just talking about the primary. You said maxillectomy. Would you want to further qualify your answer? If yes, then what is the other information you would like to know?
So I'd like to go for to check the bone involvement in MRI, bone marrow and bone cortex involvement. That will help me define whether I need to do a partial maxillectomy or total maxillectomy, what margins of bone I need to take out.
You're partially correct, but you need imaging to identify the extent of the tumor, but it is not the bony involvement you're looking at. Irrespective of
base of the skull involvement.
The involvement of the paranasal, basically the maxillary sinus, whether the tumor is extending till the orbit, till the floor of the orbit, whether it is extending, that is what you want to look at. The the bone being involved is no way going to change your management, because anyway you're going to do a infrastructure maxillectomy. That is the minimum you will do here. Okay, so the procedure which is going to be planned here is an infrastructure. This particular patient did not have any extension till the, what you can say as the roof of the maxilla. So the procedure being planned is an infrastructure maxillectomy. So that is 5 marks for you. The next part of the question is, what is the simple and complex reconstruction you will plan for this patient? Because you're going to take out almost, more than 2/3 of the palate is going to go. So what is the simple and the complex reconstruction that you can plan for this particular patient?
The simple, I can take a local flap, and in complex,
local flap will cover this defect. See, it's going to be almost 2/3.
Some muscle like PMMC or something can be taken, and for complex reconstruction, I can take a radial artery free forearm flap or a free fibular flap. Free fibular flap can be used, so these things can be used.
So tell me clearly what you want to use. You're giving me all the options of reconstruction.
So in complex reconstruction,
one complex.
Complex reconstruction, I'll use a free fibular flap.
Okay, fine. So
simple reconstruction, maybe a PMMC flap.
Okay, for this you can give Dr. Ayush Bidani 7 marks, because he's partly right. The simple reconstruction is using an obturator.
Okay.
The simplest form of reconstruction for infrastructure maxillectomy is an obturator. So it is somewhere around 2.5. Let's have it as 7 marks for you for this question. So the proposed procedure is an infrastructure maxillectomy. The simple reconstruction is an obturator. The complex reconstruction will be by using a free fibular flap, because you have to do a bony reconstruction when you are doing a complex reconstruction for this patient. You will not just replace the soft tissue alone. Right.
Understood.
Now going on to Dr. Ayush Vyas, correct?
Dr. Vyas,
you're online. You can see the picture.
Yes, sir.
Yeah. So going on to the second thing. So this is a 75-year-old gentleman who had a tumor, a squamous cell carcinoma of the floor of mouth and lower alveolus. He underwent neoadjuvant chemotherapy, had downstaging of the tumor, after which he has undergone this procedure. This is an intraoperative specimen again, and you can see something here. Can you see the two things here? This is the tongue. What you can see as the fleshy structure there, that is the tongue. And here you can see the tumor specimen as well. Now, I want you to identify again the exact procedure which is being done here, and what form of reconstruction is needed and why.
This is a mandibulectomy with the.
I want you to label the exact procedure. You're right. It is a form of mandibulectomy which is being done, but particularly what type of mandibulectomy?
I haven't read it yet.
Sorry?
Sir, I haven't read Yet,
You can just look at it and you
neck.
can tell what part is removed. That is what I'm asking.
So this is from parasymphysis part to lower
What part
inferior
of the mandible is removed? What part of the mandible is removed? That is what I'm asking.
So this is a parasymphysis and symphysis and inferior alveolar tooth.
Oh, there's a name for it. Yeah. See, always mandibulectomy is inferior alveolus.
But I name, sorry, sir.
Forget it. Okay. You are partially right in this. What about the reconstruction needed and why?
The fibula flap, free fibula flap can be used because it can make we can segment it or make a portion of mandible.
Yeah,
and
you're right in
we
saying
can,
free fibula again. Partially, you're correct. But why do you need it in this case? For example, if I
because
say
we can,
suppose the lateral resection has been done, do you think you will need a free
yes,
fibula? What will be the reconstruction you'll use for a lateral resection? What is a simple form of reconstruction you'll use? Commonest flap we'll do?
so first clavicle, we can transport clavicle from shoulder to same side of shoulder to
Clavicle.
clavicle and first ribs. So I can, sorry, sir.
What is a simple flap you will use, boss? What is the commonest flap which will be done in head and neck surgery?
So, PMMC, sir.
Yeah, you will just do a PMMC, right? If you remove the lateral sector of the mandible. I'm asking for this particular patient, you're right in saying free fibula, but why?
So we can place, we can make tooth place, we can place tooth.
No, that is all the advantage of the free fibula. In this particular patient, why do you need a free fibula? That is the question. See, for example, in the previous question, I told about using the operator and using a free fibula. Both options I have given. This particular patient, I cannot give any such option. I have to use a free fibula. Why? Okay, I think you are not sure of the answer. Let's move on. We will give you 5 marks for this question because you got both option A and B partially correct. The exact procedure which is being done is called as the central arch mandibulectomy. The arch of the mandible is removed. So the central segmental or the central arch mandibulectomy is the name that I was looking for. You are correct in saying again that we have to use a free fibula. The reason is you will develop a kind of deformity if you remove the central arch without reconstruction using free fibula. Can you tell now what is the deformity which will be there? It's a standard question. Central arch defect, what deformity will be there? Not sure? Okay, the answer is anti-gump deformity. Have you heard the term anti-gump deformity?
Sorry, sir. I haven't.
Okay, so basically, retrognathism kind of thing will happen. So that is known as an anti-gump deformity after a cartoon character. So this kind of any kind of central arch mandibulectomy resections requires a free fibula reconstruction. Bony reconstruction has to be done because you want to avoid the anti-gump deformity. Anyway, we will give you 5 marks for this question. Please note down as 5 marks for this question. Going on to the next one. So this is for Dr. Sachin. Dr. Sachin, you're there. Your chance to get 10 marks. It's a relatively straightforward question, I think. So you're there, Dr. Sachin?
Yes, sir.
Yeah. So this is the 75-year-old lady who presented to my clinic with this lesion in the oral cavity on clinical examination. So there are 2 parts to the question. What procedure can be planned for her if the contrast CT of the mandible shows no cortical erosion and there is a good mandible available? That is the first question. The second question is, if there is a cortical erosion, what is the T stage and what is the simple reconstruction option for her?
Yes, sir.
Please. Hello? You're there, Dr. Sachin?
Sir, yes, sir. If there is no cortical erosion, we can go for wide local excision.
Okay.
If there is cortical erosion, I can go for marginal mandibulectomy.
Think carefully before you answer. Where is the lesion located? Where is the lesion located, Dr. Sachin?
Sir, on the lateral arch.
Oh, what is this area? What area is this?
Sir, behind molar.
Yeah, what do you call that area? I mean, there is the subsite of the oral cavity. There is a specific name to this. It's a classical subsite. One of the 7 subsites of the oral cavity, like you say, tongue, buccal mucosa, alveolus, lip.
Yes, sir.
Heart.
Buccal mucosa.
This is buccal mucosa. Okay. I mean, you already said the answer, man. You have to clearly label it. That's all. Okay, I'll give you 5 marks for that question. See, the location of the lesion is squamous cell carcinoma, which is located in the retromolar trigone. You said behind the molars. That means it's a retromolar trigone. You should have said that answer immediately. That's a retromolar trigone lesion. In the retromolar trigone, there will be hardly any area where you can get a wide excision alone. If there is no cortical erosion also, it will be abutting the mandible. So if there is a good thickness of the mandible available, you have to plan for a marginal mandibulectomy. That is the answer that I was expecting for the first question. Yeah, for B, if there is cortical erosion, then the T stage is what? You want to take that question? What is the T stage?
Sir, it's T3.
Well, it's wrong, doctor. When there is cortical erosion, it means that the bone is involved, which makes it a T4A stage. The reconstruction option for her here will be to do a, kind of like a PMMC. I already gave it to you in the previous question. Because when there is cortical erosion, you have to go for resection of the bone. You have to do a posterior segmental mandibulectomy, and basically you have to resect the entire mandible there. And after that, the simplest form of reconstruction is to do a PMMC without doing the bony reconstruction. So I can probably give you 3 marks for this question. Please take 3 marks for him for this question. Ravi, you have noted down?
Yes, sir.
Okay. So he answered partially, so that's fine with regard to mandibular erosion and all, but just 3 marks for that question. So the next candidate, Dr. Gupta, you are ready? Dr. Ayush Gupta?
Yes, sir.
Yeah, you can see the screen.
Underwent surgery for right buccal squamous cell carcinoma post
I will give you the question. This is a young gentleman who had a squamous cell carcinoma of the buccal mucosa, pretty large. So we had given him neoadjuvant chemotherapy. Now again, this is the second picture that I want you to look closely at. I want you to tell me the exact complete name of the procedure. This is the segment. This is the, what you can say is the specimen picture. This is the reconstructed picture. So I want you to tell me the exact procedure which has been done in the second picture. And what are the 2 components of oral reconstruction?
Sir, is it a commando operation?
Yeah, it's a commando procedure, correct?
For the carcinoma of the floor of the mouth and
the buccal mucosa. Yes,
buccal mucosa. Sir, it do components of oral reconstruction. Sir, we have to.
No, it's not complete. Your answer is not complete. Commando procedure is just the resection. What is the reconstruction which has been done here?
Sir, reconstruction is a pectoralis major myocutaneous flap procedure.
Again, some more qualification is needed. You are right in saying PMMC, but is it only that? What else is there?
Tongue reconstruction could also be done along with it.
What can you see in the picture, Dr. Ayush Gupta?
Sir, I can see a pectoralis major flap taken. Along with it,
Normally, where is the PMMC flap placed?
Sir,
okay, tell me what are the 2 components of the oral cavity reconstruction? Whenever you're doing any oral cavity reconstruction, there are 2 things that you have to reconstruct. I'm not talking about bone and soft tissue. There are 2 things that you have to do. What are they?
I'm not sure. I don't.
If you know the answer to the first question, you will answer this very easily. I thought this is an easy question for most people. Okay, I'll give it
reconstruction.
Yeah, the reconstruction, you got it partially right. So I'll just give you 5 marks for this question. You're partially correct and you have answered more than that. That is why I'm giving you 5 marks. So the exact procedure which is done here is a composite resection with a bipedal PMMC reconstruction. It is not just any kind of reconstruction. It's a bipedal PMMC reconstruction that we have here. So normally the reconstruction of the PMMC flap will be on the inner surface. It will be on the mucosal aspect. That is where we'll be putting the PMMC flap, not on the outside. Okay, here we have done a flap on the inside and on the outside. Both are there. So this is a bipadal PMMC flap. That was the name of the procedure I was looking. And the two components are essentially that you line, the mucosal lining, which is called as the reconstruction of the lining, and the skin is also reconstructed, which is known as the cover. So it is lining and cover, which are the two components which are involved in this bipadal PMMC reconstruction. Okay. So yeah, so that ends the round 7. So at the end of this round 7, penultimate round for me, can we have the scores?
Yeah, we have Dr. Ayush Bhadani leading at 42, followed by Dr. Ayush Vyas at 35, followed by Dr. Sachin at 18, and Dr. Ayush Gupta at 10.
Okay. So yeah, guys, buck up. You're nearly there at the halfway mark. This is the last round that I am going to do. So this is going to be on cutaneous and musculoskeletal lesions and tumors. So first is to Dr. Ayush Badani. So this is an 80-year-old gentleman who presented to me with this condition that you can see here. This is the anterior aspect and this is the posterior aspect. The back and the chest wall you can see. Now the first question is, what is the diagnosis and what is the management for this particular condition? And the second part of the question is, if these lesions had an advancing edge with a healing center, then what is going to be your management? You can go ahead and start.
Cutaneous melanoma. So the lesion is not, I'm not able to clearly see, maybe due to, okay. Yes, thank you, sir.
Can see? Please give a further clue, actually.
So this is bilaterally distributed?
No,
If you
not
could please.
bilateral. Unilateral, you can see that it's on left side only.
Left-sided
On the
only.
posterior left side, this is on the anterior left side. The
Herpetic.
clue is in this one. The clue is actually this one, this particular thing, what you can see here. These lesions give you the characteristic diagnosis.
The herpetic this transferring from one to another, so maybe herpes zoster.
Very
one-sided
good.
segmental.
Correct. Yes, it's a dermatomal distribution of herpes zoster. Very good.
Yes, sir.
What is the management?
So it will be antivirals, acyclovir is
Yeah,
given.
acyclovir or ganciclovir or valcyclovir. Perfect. So you get 5 marks for that. Now let's see if you can get the other 5 as well. If these lesions have an advancing edge and a healing center. This is a theoretical question. This is not based on this particular thing. You already answered for that particular lesion. Remember, it's not always malignant when it comes from an oncologist.
Yes,
you have
sir.
to be ready for all kind of lesions. Just to pop out everything. So if these lesions, on the other hand, had an advancing edge and a healing center, then what will be the diagnosis and management?
So if these particular, like herpes zoster, had an advancing edge.
No. I'm saying.
Okay, sir. It can be a tinea in that case.
Sorry.
So you are asking if this lesion had an advancing edge, like if herpes zoster had an advancing edge.
It's all ulcerated now. There are
Yes,
ulcers
sir.
that are forming here. So if you get an ulcerated lesion with an advancing edge and a healing center, what will be the management?
So it might be a tinea corporis and we have to give antifungals.
Tinea, do you get ulcers?
No, sir.
I'm giving you very clearly. Look at these lesions. Suppose this had been the ulcer where one edge is progressing, the center part is healing.
Molluscum.
Okay, Dr. Badani,
Not
you got
sure,
5 of it right. So 5 marks for you for this particular question. The answer I'm looking for is a morphiform or a field fire BCC. Classically, it will present as a central lesion with a advancing edge. The center will keep on healing. The edge will keep on increasing. So it will be called as the field fire type that we call, or the morphiform BCC, the most aggressive variant of BCC. So that kind of lesion can be present, an ulcer with a healing center and a progressive peripheral area. So that is a morphiform or a field fire type of BCC. That was the answer I was looking for. So here you will get 5 marks for this question. You made the diagnosis of herpes zoster based on the vesicles. So now it is a question to Dr. Ayush Vyas. You're there and you can see the picture, Dr. Vyas.
Yes, sir.
Yeah, so this was a 85-year-old gentleman who presented with a lesion in the lower back for, according to him, a 3-month history. before that, he said there was nothing much. I just had this as the lesion, which was there. Maybe something was there. I'm not sure. That was the history he gave me. His family also was not able to give a clear picture on whether something was there because this was in the lower back and nobody else has actually seen the lesion. Now, what is the likely diagnosis and management based on the clinical picture alone?
So this is a likely squamous cell carcinoma developed on bed source, marginal ulcer.
Yeah, so clinical diagnosis is spot on. What is going to be the management?
Management is 1 centimeter margin excision with because it is more than 2
Yeah,
centimeter.
you'll go for
1
a
centimeter margin.
yeah, you'll go for a
wide
basically. That is the plan that you will have. Okay. So 5 marks for you already. Now let's see if you can get the second part of the question. Now here you can see a lot of markings which have been done and marked as P. Okay, remember what is the lesion, where it is sitting and all that. That is the clue for you. All of these 4 areas we have marked it as P at the time of before starting the procedure. See, this markings are made using an advanced ultrasound technique, ultrasound based technique. So can you know
this is likely, sir, this is vascular pedicle based on perforators.
Very good.
We can use
You
for gluteus.
stands for the perforator. So the patient, because of the elderly age group, can plan for a free flap as we would have done, because in the region, particular area, getting anything to cover, gluteal vessels will also go here because it's in the superior gluteal region. So you cannot have a flap which is based only on the inferior gluteal. So we decided to plan a perforator based flap for this patient. And what you have seen here as marked as the Doppler based perforator marking. So hats off to you. You got that completely correct. So 10 marks to you for this. Very good. I didn't actually expect you to answer this, but very good. You answered that very well. So congrats to you. That is 10 marks for you. Right. Now going on to Dr. Sachin. This should be an easy question for you. Are you there, Dr. Sachin? Dr. Sachin, are you there?
He's here. Dr. Sachin, you're on mute.
Sorry, I wasn't.
Dr. Sachin, you are able to see the picture. Please, whoever is going to answer, keep yourself unmuted. Okay. You can see the picture, Dr. Sachin?
Yes, sir.
Yeah. So this is a 96-year-old lady who presented with 2 lesions on the right heel, both of which I have marked and circled here. Okay. I want you to tell me the exact diagnosis and the most common type. That's the first part of your question. And the second procedure is what is going to be the surgical procedure and the margins. So I'll just zoom. Sorry. Just zoom this for you. These are the 2 lesions that you can see. One is this lesion, the other one is this lesion.
Yes, sir.
Now tell me the diagnosis, exact diagnosis I want.
Sir, melanoma of the...
Yes, that is partially right. That is a melanoma, but I said an exact diagnosis. I mean, it's a very clear thing. You have got a pigmented lesion in the heel and then you've got an ulcerated lesion here. So you know the diagnosis is a melanoma, but I want an exact diagnosis based on the, the clinical picture and whatever I have shown you here.
Sir, I'm unable to recall the...
Where is the location of the lesion?
Sir, on the heel.
Yeah, so what type of it will you find in the heel? Peripheries.
Sir, superficial spreading.
Yeah, so that part you got it right. The most common type is the superficial spreading type that will still happen here. But any particular thing for this area? Okay, I'll leave you a little time to think about that. What about the surgical procedure and the margins? Tell me the full surgical procedure and the margins that you will give. Dr. Sachin?
Yes, sir. Sir, here I need to know about the staging for deciding
it's
the...
a thick melanoma. You can see that it's an ulcerated thick melanoma. You can already see it there.
Okay.
Clinically, no notes. It's an ulcerated thick melanoma.
Sir, wide local excision.
Okay.
With margin 2 centimeter.
Okay, 2 centimeters. Yes. What else? That's all?
Yes, sir.
Do you remember the name of the melanoma, the subtype of melanoma?
Is the most common is superficial spreading.
Oh, that
and
I have told already.
un-
That is right. Anything else you remember? This is your chance to take 10 points. It's a pretty simple answer. These are all straightforward questions. All these you would have probably read for your exams. At least tell me the full surgical procedure. One is a wide excision with 2 centimeter margins. What else will you do? You're not sure? Okay. The exact diagnosis is an acral melanoma.
Acral.
Okay, so the answer is an acral melanoma. So what you're having is it's an acral melanoma. The most common subtype is a superficial spreading even in an acral melanoma. The management is a wide excision with 2 centimeter margins, and you have to do a sentinel lymph node biopsy. Nodes are a component of melanoma management always. Any malignancy will always deal with the nodes. That's a very simple question, doctor. I expected you to get. I mean, maybe not the acral part, but I think even that you should have gotten. Anyway, so 5 marks to you for this question. You can note down as 5 marks to Dr. Sachin for this question. Okay, now going on to the last question. This is to Dr. Ayush Gupta, correct?
Yes.
Yes.
Yes, Dr. Ayush Gupta, you're ready. You can see the screen.
Can you
Can see the screen, Dr. Ayush Gupta?
Yes, sir, I can see the screen.
Yeah, so the question to you is this. This is a 54-year-old lady who had a carcinoma of the right breast. We had done primary surgery for her. It was a right modified radical mastectomy, which has been done for her. And after giving the first cycle of adjuvant chemotherapy, this is the presentation. I'm just zooming it a little bit for you. This is how she presented to us. This is the left arm, as you can see.
Yes, sir.
Okay, so the left arm showed this kind of presentation after giving the first cycle of chemotherapy. Now, what is the diagnosis? And this is the second picture for you. Based on the diagnosis that you have, and based on that clinical picture, we proceeded with the surgery. And this was the procedure which was done for her. So the question to you is, what is the diagnosis and what is the procedure which is done here for her?
No idea, sir. Looks like edema of the limb, but I have
There
no
is edema
idea.
of the limb. See, just look at what is the history I've told you. There is one
Yes,
cycle
sir.
of therapy I said I have given.
Post chemotherapy
Okay, forget that.
lymphedema.
What is the procedure which is done here? This
I have
you
not,
should,
I have not seen this image, sir.
boss, as a surgery resident, you are absolutely expected to know this. Any surgery registrar, registrant, right from first year, second year onwards, you have to do this procedure as an emergency.
Sir, incision
Surgical procedure.
and drainage of the edema. I think
IND alone. Why would I mark it at 4 or 5 places if it is an IND?
no idea.
Oh, I thought this was a sit. Okay, the diagnosis is an extravasation injury for this particular patient. The procedure which has been done here is a fasciotomy. You can see multiple marks along the dorsal aspect wherever there is edema. You have seen, here you've gone to the level of muscles. This is a fasciotomy. Here again, you can see it's a fasciotomy. I definitely thought you will get the answer as fasciotomy.
Yeah, incision meant that only. Well, I should have told the exact term fasciotomy, but I meant.
It's very clear, boss. I don't think anybody would have missed that. You're going across the palmar crease here. Ventrally, you're putting, dorsally, you're putting, every aspect you're putting. The fasciotomy should have been a clear answer. Anyway, what procedure, now that you know that there is an extravasation and you have done a fasciotomy for this lady on the left side, okay? And this is a patient who is on the right MRM. What procedure will you plan before the second cycle? You let her recover and 3 weeks later, you're planning for chemotherapy. Now, considering that this has happened to her, what procedure will you plan before the second cycle of chemotherapy? You have to still give her chemotherapy. She needs 6 cycles of chemo. It is only the first cycle which is over. So to continue the chemotherapy, what procedure will you do?
I will, sir, in the systemic, no, in the systemic circulation, I could give the chemotherapy if this is the cause of leading to the
How?
Using the central lines.
Yes, I'll partially give it to you. Is there something more specific which will be used in chemotherapy patients?
The chemo port you can insert with the subclavian line.
Finally, okay. So the answer is a chemo port. Okay, either a subclavian or an IJV chemo port will be done. See, remember, in a patient with breast cancer, you can use only one limb. You cannot use both the limbs. After a right modified radical mastectomy or a right axillary dissection has been done, after SLNB you can use, but after a modified radical mastectomy where the axilla has been cleared, you cannot use the ipsilateral limb for any IV injections or IM injections. You use only the left limb. The left limb has been used here and it has undergone a fasciotomy after an extravasation. So for this particular patient, we will go for a chemo port. So that is the answer. So you will get 5 marks for this question. You have gotten 7, but anyway, you've gotten 5 marks. Thankfully, you picked up the clue there. And yeah, that's the end of this 4 rounds for me. Ravi, you can give the scores now at the end of 8 rounds at the halfway mark here, I think.
I hope you can see the screen, sir.
Yep, I can.
Yeah.
Go ahead and read the scores.
Yeah. So we have Dr. Ayush Badani reading at 47. For very close to Dr. Badani is Dr. Vyas stepping up at 45. Then we have Dr. Sachin, who still has a big way to go, and Dr. Gupta, who can also challenge Dr. Sachin and Dr. Vyas. So at 23 and 15 respectively.
Okay, friends, all the best again. So you have been doing reasonably well, but you need to buck up to catch up. Dr. Ayush Badani, keep up your lead. Dr. Vyas, you are almost there. So both of you have a very high chance. Don't give up your lead. Other two, you can still pick up because it's all 10 marks per question. So all the best, my friends. I'll now hand it over to Dr. Venkatesh to start the next session.
Thank you, sir. Am I audible?
Yes, sir. You are clearly audible and visible.
Okay, am I audible? Okay. So I would like to share my screen now. So first of all, at the outset, this is it visible? Is my screen visible, guys?
Yes, sir.
Okay. Right. So first of all, many congratulations to all 4 who have been gone through this prelims and taken part in this. So all of you are, in my opinion, are equally winners. But anyways, when it comes to quiz or any competitive thing, there has to be standing on that. So far it's been closely fought between all 4 of you guys. So given the level of questions, I think my questions will be slightly the lighter side. Am I audible?
Yes, sir.
Okay, so I think my questions will be more on a lighter side because I feel quiz should be you should know the answer. It should be so close yet so far. That kind of feel quiz should give. I feel that way. So most of you would be able to answer these questions. There are so many clues in these questions which I'm going to post. So I'll be having 3 rounds of questions. So instead of going through the system wise, I have divided them into 3 rounds. So the first round will be like where you are taken to have a peep into the operating room. So I'll be showing some intraoperative pictures on various urosurgical procedures. And I would like to ask you some very simple questions out of it, and I expect you to answer it. Each question will have 2 parts. As you say, each part carries 5 marks. Okay, so if you answer both the parts of the question, you'll be given 10 marks into it. And next thing is next question will be next round will be on some uroradiology, which we call as the third eye in urology, because unlike most of the other specialties, urology, you don't get to see many clinical findings. So most of the times your investigations, your clinical diagnosis is based on imaging. So radiology is the third eye for all the urologists out here. So that will help you to get into the accurate diagnosis and design the management. And finally, we are not here because if we don't remember the legends on whose shoulders we are standing and all the new evolutions are happening. So in any quiz, I feel we should take some time to go back and think back our legends who had contributed greatly in the field of surgery and urology. So most of these legends you may know, you may not know the picture, but I'll be giving you enough clues for you to find it through that. Okay, so I want all four of you to enjoy these 3 rounds. Okay, I'm very sure that all these questions will be very light and will increase your mood, will lighten up the spirit of all four of you guys. Okay. So with this, we'll go into the first round. So I'll be taking the rounds question through the same session, right? First is Dr. Ayush Badani. Next is
Sir,
Ayush.
the order is completely
Is the same.
your
Fine.
call.
Okay.
Your call. We can go 4-3-2-1 also.
No, anything is okay. So far, it's been going like anyway. The questions are all randomly chosen. So, anyways, we'll go with that. Okay. The first question, we'll peep into the OT room. So first question is like once again.
Past 2 years are difficult.
Okay, so first I will just present you a small clinical capsule, and based on that we will I'll post the surgical pictures. Here is a 42-year-old male who presented with difficulty in passing urine for the past 2 years. He was evaluated and was diagnosed and is being posted for a surgical procedure. So these are some of the intraoperative pictures during the surgery that is being taken, being done. So first is one image, and followed by you have 2 intraoperative pictures, and this is actually we are operating through the perineum. Okay, so these are the pictures you have. So is the pictures visible, adequately visible? Yeah.
Yes, sir. So seeing the age
Your
and
time starts now, Dr. Ayush. Yeah, you can go ahead.
Last 2 years difficulty in passing urine. I see a retrograde ureterogram. I see there's a stricture which is there.
Yes,
second picture shows the buccal mucosa. Third picture shows that there is some stricture and incision has been made for the perineal approach. So I think this is a urethral stricture repair by using a buccal mucosal graft.
Okay. Can you just be more pinpoint on the exact procedure? What is that urethral surgery? I don't need the
mucosal graft urethroplasty. Buccal mucosal graft urethroplasty.
There is one particular name, one particular adjective which actually qualifies that surgical procedure. So I don't need the name of the name by which it goes by the surgeon who first detected it, but I need a more qualified answer on it. So you are right on the first part. It's an urethral stricture.
Bracas procedure. Bracas.
No, it's not Bracas, but this is actually what you see here is like, first is a picture of RGU showing a bulbar urethral stricture. Next is a intraoperative picture taken through the oral cavity where we have marked the graft and we have taken an oral mucosal buccal graft. And third is the perineal exploration where we have opened up the ureterotomy is done, and we have taken this buccal graft and we are suturing there. Okay, so this is actually a urethral stricture, and we go for a buccal mucosal graft substitution ureteroplasty. I'm looking for the term substitution because here we are substituting a part of the buccal mucosa in place of an urethra. So that's a more qualified, because there is other forms of ureteroplasty as well, like augmentation and end-to-end anastomotic ureteroplasty and stuff. So I would have preferred to have this buccal mucosal graft substitution ureteroplasty. In fact, the procedure which we have done here is called Barbagli's Darcy, which I feel is little too much for you guys. I didn't expect you to answer, but the substitution should have been a better term to answer. So can we have 7 marks? 7 marks for Dr. Ayush here. A very good answering and good. Ravi, can we make a note of it? We can award 7 marks to Dr. Ayush. So next we'll go to the next question. Okay, Ayush Vyas. So here is your question. Here's a 13-year-old girl who presented with a right loin pain for past 6 months. She was evaluated, she underwent a series of investigations, and she is being posted for a neurosurgical procedure. I want you to identify the probable diagnosis and what is the procedure that is being done here. Okay, right. Can you see a small clip running around here?
Yes, sir.
Okay, if you want, I'll play it again. She presented with right loin pain, and you see few structures here, one structure over here and a couple of structures this way. So this is the next thing. This is after the end of the procedure. something is again done here. I want you to identify the probable diagnosis and probable procedure which we have done here. I'll just play the clip again. Very simple. Don't complicate yourself. Most of these questions you would have known the answers. It's all from Bayesian law. All what I have done is added the clinical component to it. Okay, it's time for you to answer. What could be the probable diagnosis? And what do you see here? Especially if you see in this, that will tell you that will clinch you the diagnosis. Are you sure there? Just take a wild
Yes,
guess.
sir, yes.
Yes.
So this is
So shall I go to the next one?
this is
I would prefer you to just attempt something. Just give a go at it, Ayush. Nothing to lose.
this is urethroplasty.
No, that's not the right answer. So the answer here is it's a case of a suspected right side PUG obstruction, and whatever you saw here is your these are the lower polar vessels. Okay, this is the probable PUJO with the lower polar crossing vessels here. Okay, lower polar crossing vessels here, which is actually causing the obstruction. Understand? This is the lower polar artery and the vein, and this is your PUJ, which you see here. Understand? Right. Okay. So what you have done is we have done a dismembered Anderson-Heinz pyeloplasty. Obviously, if you see here, this is a oh my God. Okay, right. So obviously, what is the procedure done here now? You see some big tower-like structures happening there. So this is actually a Da Vinci robot. It's a console or surgeon console. That's a patient card. What we have done here is a robotic-assisted laparoscopic right Anderson-Heinz dismembered pyeloplasty. Okay, so unfortunately, no marks to be awarded for Ayush as he has not attempted this question. So next is the third question. This is a case capsule. A 39-year-old male presented with a coital trauma followed by sudden detumescence and absent erection. He is being posted for a neurosurgical procedure. And these are the intraoperative findings. Okay, this is a preoperative picture, and something is being done here. And I want you to come out with the probable diagnosis as well as the surgery that is being done here.
Sir,
Sachin?
yes, sir. The diagnosis is this is traumatic penile fracture.
Okay.
And the surgery.
What is being done here? What do you see in this in these images? I hope the images are clear, right?
Yes, sir.
Yeah.
Sir, by images, I am unable to recall the surgery. Sorry, sir.
Okay. Don't complicate yourself. I don't want you to give any fancy names or stuff like that. Okay, anyways, you can award 5 marks to Dr. Sachin on this part because he has answered it's a typical case of a penile fracture. The history is typical following a coital trauma. It's an eggplant deformity. And as you see here, you see a hematoma here. And what we do is in any penile exploration, we do a penile degloving procedure and we are going to explore the penis. So what is a penile fracture? It's nothing but a fracture. It is nothing but a breach in the tunica albuginea or the corporal bodies. As you see here, these are the corporal bodies here. These are the corporal bodies. Okay, so what has happened is there's a breach in the tunica albuginea of the corporal bodies. This is the urethra here. Okay, so what you have done is we have sutured the corpora. What you have done is a penile exploration, degloving, and we have done a primary corporal repair. Okay, so that is the whole procedure. Okay, I think you were looking for some fancy names and you got carried away, I think, Sachin. Okay, anyways, 5 marks to Dr. Sachin on this part. Next, we will go to the Next question. Okay. Okay, it's a penile fracture and it's what is being done is a penile exploration and corporal repair. Next is the fourth question. This is a case capsule. A 63-year-old male presented with a recent onset phimosis and a swelling in the inguinal region. He was diagnosed and is being posted for a urosurgical procedure. And these are the pictures you are going to get. Okay, this is an intraoperative picture and one is the post-operative picture you see here. I want you to identify the probable diagnosis and what is the procedure which is being done here. So I think Ayush is with us, right? Ayush,
Yes,
yeah.
sir.
Okay, yeah. What is the probable diagnosis? He presented with a recent onset phimosis and a palpable swelling in the inguinal region. And what do you see here? Want me to focus up?
Sir, probably some recent. I've never seen this image, sir.
Sorry?
I've not seen this image, sir. I don't know.
Fine. Okay. At least you can give a guess. You can give a guess.
Recent onset phimosis with sir, it might be due to some blockage of the lymph of the venous supply leading to the edema of the penis and leading to subsequent phimosis. It might be the cause. And
you very clear as a right inguinal swelling. What do you think is a right inguinal swelling? Dr. Venkatesh is giving very classic scenarios here. I think all
Yeah.
this question.
I specifically wanted to give them very easy clues there so that it is easier for them to identify rather than making it difficult.
I mean, see, you can actually see it is a big something has been taken, some tissue has been kept there, and abdominal surgery. You can see something inside. You just zoom your thing and see. You can very clearly see the surgery. It is. I mean, there is no way you can mistake it for anything else.
Yes. Okay. Anyways, I think I'll come out with the answer. See, as you see here, we have actually removed a part of the penis. Okay, so if any recent onset phimosis in an old man, you have to suspect carcinoma of penis. Okay, a partial penectomy is being done here. Okay, and a neourethral meatus is being made in the penile stem. And we have what I have said is a palpable swelling in the inguinal region, which is nothing but your inguinal nodes. Okay, so any recent onset phimosis probably a CA penis with a inguinal node. So what we have done here is we have done a bilateral ilioinguinal pelvic lymphadenectomy, and because it's an advanced thing, and if you see many patients do have flap necrosis, what you have done is you have done a bilateral tensor fascia lata flap closure. Okay, we have fashioned a flap from the lateral aspect of the thigh, TFL flap, and we have rotated it and made a bilateral TFL flap. And this is by a lower midline extraperitoneal incision. We have lower midline incision. We have also removed the pelvic lymph nodes. Okay, right.
Yes.
Okay, so no marks to Dr. Ayush here in this part. Okay, right. So next, so it's a carcinoma penis, and the procedure which is being done is a partial penectomy and ilioinguinal block dissection with tensor fascia lata flap cover. Right. So next we'll go to the next round, which I called is your third eye, which is your uro imaging. Okay, right. So the first question goes like this. It's a 30-year-old female who presented to casualty with complaints of left side flank pain following a trivial fall. On evaluation, she was found to be anemic, and a CECT revealed the following findings. So what is the likely diagnosis and how will you manage this case? I think Ayush Badani is the first person to take, right?
So
okay, Ayush, are you okay with the clinical scenario? You have any
yes.
doubts on it?
Yes, sir. So this looks to me like an angiomyolipoma of the left kidney, and I'll manage this case depending on the size. If it's more than 4 centimeter or symptomatic, I like to go for a nephrectomy or partial nephrectomy. If it's less than 4 centimeter, I can observe. But in this case,
okay, I think you are in a rush, but I would have preferred you to answer to be more specific to this case, right? Okay, first of all, your first part is right. It's an angiomyolipoma. Why do you say it's an angiomyolipoma, Ayush?
So in the CT, I see fat in the content. It's a mass, and the attenuation filament looks similar to the fat.
So excellent. The first part is right. So I offer you 5 marks on this question, but the second part was not so great because.
Can I answer again, sir? So it's a flank pain. She's anemic, and the CCT is revealing this. So if I can angioembolize, then I'd like to go with angioembolization if the patient is stable. If it's unstable, then we'll go for a laparotomy and look at the kidney and do an nephrectomy if needed.
Yeah, that's right. But I would not like to give you the second part because that's what you are in a rush. If you had just taken some time, because the patient is presented to ER, she is profusely bleeding, she is anemic. So there is no point in being stable or stuff like that. You have to go for a selective angioembolization in this case. So 5 marks to Dr. Ayush. Yes, that's what, like, you all know the answers. Answers are pretty well in front of your eyes. So all we have to take is a little bit, a couple of seconds to analyze, rethink, and present it in a better way, right? Very good, Ayush. It's an angiomyolipoma of the left kidney, and the patient presents perineal hemorrhage, and she needs a selective angioembolization. And if she is unstable, then we can go ahead for a exploration. And most of the times, without selective angioembolization, if you explore, you end up doing a nephrectomy in an emergency setting, right? Right. So identify the second question. It's quite simple. So I want you to name the investigation which is being done here, and what is the classical sign, and what is the probable diagnosis.
So this is IVP, and this is neurogenic bladder, and this is Christmas tree appearance.
Sorry?
Christmas tree appearance, neurogenic bladders.
And what is the probable, what is the investigation which is being done here?
So this is IVP, intravenous pyelogram.
Okay, so you're partly right. So this is not an IVP to be perfect, because as you see here, we are seeing this is a cystogram. This is a cystogram which is being done here. As you see here, the bladder is irregular with multiple Christmas tree or fir tree like of pattern. And as you see here, there is a faint radio opaque, there is a radio lucent area. So this is nothing but this is being occupied by your Foley catheter inside. Can you see this? It's a Foley catheter where the contrast is being not taken up. So actually we have retrogradely put in a Foley catheter and we have done a filling cystogram in this patient. And as you see, there is an additional finding here. There is, even in the filling phase, because of the poor compliance of the bladder, you tend to have a left-sided vesico-ureteric reflex. This is not an IVP, but this is a cystogram. But the rest of the part is right. It's a classical fir tree appearance, and it is typically seen in neurogenic bladder where you have this detrusor and sphincter dyssynergia. So I think we can offer 7 marks to Dr. Ayush, right? Ayush Vyas. Who is the one who answered now?
Yeah, Dr. Vyas it was. Sir,
okay.
To Dr. Ayush Badani, what were the markings to be awarded?
That was 5 marks because he missed the second part in the right time. Okay, right, okay. So now we'll come to the third question. So what is this investigation? What is a typical sign you see here? And what is the probable diagnosis? Dr. Sachin, your time starts now.
Yes, sir. Sir, this is right ureteric obstruction. The sign is reverse.
Sorry, I could not hear. Yeah.
Yes, sir. This is a reverse J sign.
Okay. Where do you find this? Okay, I think it's time up. So it's a simple, straightforward question. So it is an IVP, as you said. And what you see here is you see a seahorse or shepherd crook deformity, or sometimes people do call it reverse Jason. Anyways, I'll give that to you. Okay. And where do you see this? Because this obstruction is, because this ureter is going beneath the one important structure which comes over here. What is that on the right side? This is typically seen in retrocaval ureter. Because of the retrocaval ureter, the ureter goes behind the IVC. So that retrocaval part of ureter gets atretic and it is obstructed. Okay. So this is typically seen in retrocaval ureter. So I think I would like to offer 5 marks to Dr. Sachin here. Okay. So the typical sign is what we call as Seahas or shepherd hook deformity in IVP, and it's a retrocaval ureter. So next to the fourth one, it's again a very simple thing. So identify this investigation which is being done here, and what is the typical classical sign you see here, and what is the probable diagnosis?
Sir, it is most likely the polycystic kidney disorder, the cystic disease of the kidney, of the right kidney.
Okay.
And sorry, depending upon the age, it could be the autosomal dominant or autosomal recessive or the polycystic kidney. The sign, it can rosette appearance or multiseptated appearance.
So unfortunately, the answers are wrong. So there is no marks to be being awarded to you. But I will tell you, this is typically what is called as a bear paw sign. Okay, bear paw sign. It is, remember, like a paw of a bear. Okay, like it has got a, yeah, if you say the name, it is easy for you to answer, but I wanted you to pick it from the images. Okay. It's a typical image. You see an enlarged kidney because there is calyceal dilatation which appears like a bear paw, and you have a centrally obstructing large calculus. Okay. And this investigation is a contrast CT. So mostly it is a non-functioning kidney, typically seen in xanthogranulomatous pyelonephritis. Okay. Right. That's what you know everything. If you, the moment I say bear paw sign, then you see everything. So, but you have not taken time to assess the image. Okay, that is what I want you to get it done. Okay, right. So all the questions will be very simple, and the answers will be right in front of your eyes. I just want you to analyze, take a couple of seconds before answering it. Right. Okay. Next, we will go to the next third round, as I always say. So we should remember our legends, because on their shoulders, who has contributed immensely to our field, we are actually doing a better clinical work. So these are those people who, in those times, who are not fortunate to have the opportunities like us, they relentlessly work in the day and night to help us to for the betterment of the patient care as well as the clinical diagnosis. Okay. So there are here I will be showing images of 4 important surgeons or legends, whatever we call them, and there are adequate clues to it. Even if you don't know them, with the help of clues, I want you to come out and answer. Okay. So with this, I'll go to the first question. So name this legend and his contribution. So the clues are in the adjoining pictures. Dr. Ayush Badlan. So, are you there? Yeah. So what is being?
So this is a bilateral superficial lymphadenectomy, and Dassler or Catalona. I'll just think and answer, sir, this time.
Sorry?
The template is Dassler's template is made.
Okay.
And the mark is the superficial I'll go with Dassler.
Okay, I think you had it, but
Catalona, sir. This is superficial lymphadenectomy, and in between the adductors. So Catalona, Professor Catalona, Dr. Catalona. Like his contribution is that he gave a superficial lymphadenectomy, and we can avoid doing we can avoid doing the radical lymph node dissection. So superficial Catalona, sir. I'll go my answer as Catalona, sir. Final answer.
What can I do for to this? So we are in a hurry because you gave a.
Okay. So final answer,
Catalona. Can give 5 marks because. Sir,
yeah, that's what, sir. I'm also thinking on that because
yeah.
Because the answer was correct. So that's why there is a rush. because there is no one else to answer. It's your time. Take your time and analyze. So you're right. It is Catalona's modification. But what is Catalona's modification? It's a superficial node or it's a complete superficial and deep nodal dissection?
So it's a complete superficial and deep, but we basically only do the dissection in 1 and 5.
I know, doctor, but you said Catalona is a modification of a superficial node dissection. Catalona,
Yes.
in fact, includes both superficial
Both
and deep
superficial and
nodes,
deep.
but it is a less morbid procedure compared to a standard radical lingual lymphadenectomy. Understand?
We don't,
wherein
yes.
the boundaries are being limited, and we don't go for more lateral and extensive nodal dissection, which may lead to a significant lymphedema. Okay, because initially the original template of radical lingual lymphadenectomy was done for melanoma foot, where there was a need for an extensive lymphadenectomy, lymph node dissection. Whereas when it comes to penis, which is a more central organ, we are very much worried about the medial group of inguinal nodes. Okay, so it's a Catalona. It is Professor Catalona, and it is his he devised this Catalona's modification of inguinal lymphadenectomy. I would like to offer 5 marks to Dr. Ayush here. Please make a note of it. And it is Professor William J. Catalona. So next is name this legend and his invaluable contribution in the field of medicine in general.
This is Foley.
Okay.
And
what were his contributions?
Contributions, he introduced Foley's catheter for acute urinary retention for Foley.
So what is the uniqueness of Foley's catheter and why it stood the test of time for so many years?
Sir, this is self-retaining Foley's
Yes.
catheter.
So before this, there was no model of self-retaining for urinary catheter system. So as you rightly said, it is Professor Eugene Frederick Basil Foley, and he is the first person who devised the self-retaining urinary catheter, which still goes by his name, by Foley's catheter. And remember, he is also he was also the first person who devised the first hydraulic operating table, and he has devised a TURP resectoscope on his own. Understand? Right. So next we'll go for the third question. So name this famous person and what is his contribution in the field of urology. Or I would give you a clue on that. He has immensely contributed in the management of prostate cancer. He is one of the very few physicians who's been awarded the highest
Nobel Prize.
Sorry?
One of the surgeons to receive a Nobel Prize.
Yeah. Okay, so you got it. But the question is not that. I want you to name him and what is his important contribution.
I answered. This is Balaji.
Okay. Oh, sorry. So you're not supposed to answer,
I
sir.
was just giving the clue. I was just giving the clue.
Okay.
Nobel Prize he received. Yeah.
Yeah, that's why I just wanted to say. I just wanted to remember those all big doyens on this day, sir. Like. So, and I have given you adequate clues on it. There is an injection which goes by a name Leuprolide, and I also gave it is very much useful in the management of prostate cancer.
Sir, I don't know his name, sir.
Okay, but at least you can try his contribution or stuff like that. I know it's a very tough question. Like, anyways, because he is one of the very few surgeons who has been awarded the Nobel Prize. He received Nobel Prize in 1966. He is.
I will give you one more clue. The contribution with regard to what he did for prostate cancer. That is the clue.
Yeah, that's a clue. That's what I wanted to. Even the Nobel Prize.
Prostate cancer. Think of it like that.
So, what do we do in metastatic prostate cancer? Okay, anyways, now at least we are out for discussion. What is the treatment for metastatic prostate cancer? Sir, I think Sachin is there, right? Yeah, Sachin,
yes,
please.
Yes, sir. Yes, sir. Sir, we use this injection, leuprolide acetate.
Okay, what is this injection and how does it work? Okay, see, He is nothing but he is Professor Charles Higgins. He's been awarded the highest prize of Nobel Prize in 1966. He was a person who first discovered the effect of androgen manipulation in prostate cancer. What he said was, if we reduce the testosterone levels, it is going to significantly reduce the impact of the prostate cancer and and its manipulations in the patient. So olden days, before the advent of this, as you know, prostate cancer was notorious to have bony mets, and most of these patients in metastatic stage, they have terminal significant bony pain, which is very difficult to manage. So with this manipulation, then came the lot of androgen manipulating drugs like LHRH agonist or simple orchidectomies, where we take out the testosterone stimuli, so that giving extremely very good palliative pain relief and care in these patients with metastatic prostate cancer. Understand? Right. Next, my last question. So identify, name this person and what is this important contribution in the field of surgery in general. So the options are the clue is right in front of you, next to him.
Sir, it is a laparoscope.
Okay.
Used in the minimal invasive surgery.
Okay.
Sir, scientist, I am not sure the Jacobius or laparoscopy, but I don't know the scientist.
Okay. So what is his contribution? At least.
Sir, the endoscopic, he might be inventing the rigid and the flexible, the ureteroscope for the procedures might be. I'm not sure, sir. Just a guess.
So I think if you're just gone through the projection, whichever I have put in, the answer is right in front of you. So he
Hopkins.
is nothing. He is Dr. Hopkins. Sorry, the time is out, and the answer is right in front of you. He devised the Hopkins rod lens system, which completely revolutionized the field of endoscopy and laparoscopy. So previously, we used to have a lot of convex small lenses and with a lot of air pockets in between them. So what he devised was, he completely changed this concept. Instead of placing small glass lenses, he devised a cylindrical glass lenses, thereby reducing the space between the lenses, where instead of glasses, the air itself acted like a magnifying medium. So this gave a very sturdy system to your laparoscope, also your endoscope system. Okay, and he also devised the first flexible light cables using a fiber optic technique. Okay, and still it goes by the same. It is called Hopkins rod lens system. Understand? So this is Dr. Harold Hopkins, and he devised the famous Hopkins rod lens system, which is still in use after so many years of his invention. Okay, so with
for the answer, maybe just as we can give it to him properly.
Okay, 5 marks. Okay, I'll give you 5 marks to this. Okay, so because I was the reason was the Hopkins name itself is there in the projection. So that's why I felt so bad on it. Okay, 5 marks can be offered to you, right? So I think most of you answered my set of questions well. So Ravi, can you just project the scores at the end of for 11 rounds? So Dr. Ayush Badani with 64, Ayush Vyas with 62, Dr. Sachin with 33, and Dr. Ayush Gupta with 20 marks. So it's a neck-to-neck fight happening between Ayush Badani and Vyas. And still a lot more rounds to come for Sachin and Ayush Gupta to catch up. So anything can happen. See, remember, it's a quiz. Anything can happen in last couple of rounds as well. So all the very best for the subsequent sessions. Thank you so much from my end. Wish you all the very best.
Thank you.
Thank you, sir. I welcome Dr. Rahul, who will be taking sessions on pediatric surgery. Welcome, Rahul. The floor is yours. Rahul.
Yes, sir. Thank you, sir. Thank you, sir. Thank you so much, sir. Hello, dear friends. I'm Dr. Rahul, pediatric surgeon. So I think it's been a blast of questions from urology, oncology, and gastro. So I've actually modified and tried to keep my questions very simple, smart, because it's already getting very late. So just going into there are actually two rounds. Okay, the round one is with regards to infancy and pediatrics. The round two is going to be neonatal surgery. So I'm just sharing the slides for you to catch up. Can you see my slides, friends? Can you see my slides?
Yes.
Ravi, is it visible to you?
Yes, sir.
Yes. Visible, sir.
So we'll just start off with the questions, and it's going to be one question each in round 12 and one question each in round 13. Okay. So who's going to be the first one to answer the first question? Ayush, right? Okay.
Dr. Ayush Badoni, sir.
Yeah, Ayush, here you go. Okay. This is a 6-year-old girl who presented with recurrent right abdominal pain, more confined to right hypochondrium, non-bilious vomiting on and off, and multiple episodes of pancreatitis. Liver enzymes were slightly on the higher side. There was no jaundice. Ultrasound was actually normal. So an MRCP shows a mildly dilated distal common bile duct. There was no evidence of any cystic structure in the choledochus. What do you think is the most likely diagnosis, and how do you manage it? Yes, Ayush?
Sir, is this mentioned no choledochal cyst?
No. This is there
Could you,
was no
actually the
evidence of
screen, there
choledochal
is some
cystic. Yeah,
freezing on my end. So could you please repeat the question, because
yeah. I'll just get it. This is a 6-year-old child who had recurrent episodes of pancreatitis, a right hypochondrial pain, and non-bilious vomiting on and off. So ultrasound was done. Ultrasound shows no evidence of any cystic structure to classify it as a classical choledochal cyst. MRCP again showed no classical cystic structure like in a choledochal malformation, but a mildly dilated distal common bile duct approximately around 8 millimeter. So the no choledochal cyst was seen, and the line is put up just to make you think a variant of something like a choledochal cyst.
uh, abnormal biliary pancreatic junction, no recurrent upper abdominal pain, vomiting, multiple episodes of pancreatitis. Okay, liver enzymes are mildly elevated, no jaundice, ultrasound normal, and distal common, no choledochal cyst. Sir, any annular pancreas which is causing the
No, see, I'll just put it in this way.
could
This
you
no
please
choledochal cyst seen, the line is just put up to have an idea that this is no classical cystic structure like a choledochal cyst, but this is a variant or somewhere in close to choledochal malformation. So don't go outside, just go inside the CBD itself. Something features which are like a choledochal malformation, but it is not actually a choledochal cyst. It is something in between.
so abnormal biliary-pancreatic junction?
The child has got an abnormal pancreatic biliary junction.
Yes, sir.
So what
That
do you think
is
this is?
so that is leading to reflux, and that is
No.
leading to inflammation and pseudo-dilatation of the distal CBD.
So
Also, there
what do
is
you call this? I just want the diagnosis in this. What do you have a picture? It has not evolved into a complete choledochal cyst, but it's just in evolution. I've nearly spelled out the answer. It is just a choledochal malformation in evolution.
okay. So pseudocholedochal cyst or
ये
something.
वो है इसका प्रीकर्सर पूछ रहा है कोलिडोकल टेस्ट का प्रीकर्सर क्या होता है
Ayush, I can hear whatever you're telling me.
That is Ayush Vyas, sir.
Ayush Das, yeah. Ayush Vyas, I can hear whatever you're discussing. Yeah.
सॉरी
No, you are helping Ayush Badani, by the way.
So it's a precursor of a choledochal cyst due to secondary abnormal
Yeah, what is that?
biliopancreatic
What is that known as, ma? What is that known as?
total bilioma.
Okay, right. I'll give you the answer. It is a form A first A choledochal cyst. Okay, it's a
Okay,
form A
form
first
A.
A choledochal
Okay.
malformation. So, what do you
So
think
that
is the management? So, I'll give you marks partly if you can give me the answer for the management part. What do you think is the surgical management? Or it's medical? You observe. What is the management?
so we can observe, we can do a sphincterotomy, ERCP guided, or maybe put a stent.
Okay, that is the only thing we don't expect you to do. Actually, any form of choledochal malformation with recurrent episodes of pancreatitis, it is always mandatory to treat it like a choledochal malformation. So you do a choledochal, cyst excision. That way you excise the malformed CBD and then do a Roux-en-Y hepaticojejunostomy. Okay, that is going to be a treatment of choice. Now the second one is going to be Ayush Vyas, right? Okay, now Ayush Vyas, this is a 6-month-old infant with a prenatally diagnosed CPAM in the left upper lobe. The child is currently asymptomatic. The lesion occupies somewhere around 20 to 25% of the hemithorax and CT. There is no infections at all. Child is totally comfortable. We just want to know what is the management. Is it surgical, non-surgical? Number one. If is it surgical or non-surgical, we want you to reason out what is the reason you're going to wait or do a surgery.
So we will surgically excise this because it can convert into carcinoma. There can
Good,
be chances of
chances
yes,
of
chances of developing bronchogenic carcinoma from CPAM.
CPAM into bronchogenic CA, you mean?
Yes, sir.
Okay, anyway, I'll give it to you. Ayush, you get 10
We
points
can
on this. Number one, any CPAM has to be operated. Number one. So it is going to be surgical management. There is no role of non-surgical management at all. When do you do surgery? You do an elective lobectomy at 6 months of age.
yes,
So
sir.
antenatally, we just look at something known as a CPAM volume ratio. If at all the CPAM is going to increase in size, first you're going to give a dose of steroid. You're going to see if it's going to shrink. If it doesn't shrink, child goes in for hydrops fetalis. You do a fetal lobectomy. If the child is born with a CPAM, you confirm the diagnosis. If there is recurrent infection, you go ahead early. The child has no infections. Yes, you operate at 6 months of age. An elective lobectomy is done. Why? Because the child can have recurrent episodes of pneumonia. Number two, yes, for long chances of malignancy. And the malignancies are adenocarcinoma, bronchoalveolar carcinoma, or sometimes a dreaded malignancy such as pleuropulmonary blastoma. It is a dreaded malignancy. So I give 10 points to you on that. Next one. Who's the next one?
Sorry to interrupt, sir. Did I get any marks for the previous attempt question?
I think no, ma, because I think the diagnose itself was not made, right? So because you just thought about abnormal pancreatic or biliary junction, we'll give you 3 marks on that.
Okay, sir.
Sir, I lost the connection, but I joined again.
Sachin, you are on the third question, right?
Yes, yes, sir.
So you're right on time. So this is a 5-year-old boy who presented to the emergency with intermittent colic abdominal pain.
Sir,
The non-bilious bomb.
I'm unable to see the question on screen.
Ayush, are you able to see the screen?
Yeah, we can see it, sir.
I think, Sachin, I think something abnormal on your end.
Dr. Sachin, you can try quitting and rejoining. In the meantime, we can take this question for Dr. Gupta.
Okay, sure.
Yeah.
Dr. Gupta, you're there?
Yes, sir, I'm here.
Okay.
A 5-year-old
Screen,
boy with a
Ayush.
non-diagnosis presented to the
No, it's a
emergency room with intermittent polyp pain, non-bilious vomiting, difficulty, febrile, examination with distended tympanic abdomen with a localized tenderness in the periumbilical and the target sign. Sir, it is the intussusception.
excellent. So initially it was a non-bilious, and second time, as time progresses, it became bilious for this kid. Interception, yes. What do you think is the other clinical sign you should watch for?
Sir, the
This is a 5-year-old boy. You have an interception. This interception, what do you think? Do you think it is an ilioileal or ileocolic interception?
sir,
Initially non-bilious, then bilious.
Initially non-bilious, then bilious, or then it is the 1 second, sir. Intermittent colic pain, non-bilious vomiting, and lethargy. Sir, yes, sir. It look like a small gut is distended in the
Excellent, excellent. So it is more of an ileoileal interception.
ileoileal
Ileoileal
intersection.
interception, 5 years old child. So
Yes,
is there any other clinical sign? Because we know we are
sir.
going to look at pathological. Yes,
We
yes.
if he passes with this, if he and the pain is relieved by the stool passing or the not.
No, no, Ayush, I was interrupted by your connection. Now, it is an ileoileal interception, 5 years
Yes,
old
sir.
boy.
Sir, we can see the typical red currant jelly stool appearance of the if the patient passes clinically intermittently. The target
Yes,
sign or
can
the
see.
pseudokidney sign can be.
Yes, excellent. So we are looking at something of an ileoileal. What I want you to tell me is it is going to be ileoileal interception. So we are
Yes, sir.
thinking of some pathological lead point. So if there is a pathological lead point in a child, in a 5-year-old, in the small bowel, say for example in the jejunum or in the proximal ileum, we have lead points. And if this lead point is obviously going to be a polyp, then a polyp, ileoileal interception, 5 years old child. Is there any other clinical sign you look for?
Sir, the polyp in a 5-year-old uh, clinical sign.
Something in the
Mm,
face, near the lips.
sir, the Peutz-Jeghers syndrome, the hyperpigmentation.
Excellent, excellent. So what do you look for?
So I look for the hypermelanotic macules over the skin and the.
Excellent, excellent. So that is what I was looking to. So it's a Peutz-Jeghers. So you look for any other clinical sign. Yes, you look for hyperpigmentation, and you should always remember as age advances, this hyperpigmentation may disappear. And it is
Yes.
not only your perioral region, you also look at the perianal region also. So it is an
Yes.
excellent answer. Yes, you do a laparoscopic gastric enterotomy and polypectomy after reducing the interception. You just convey them regarding the need for surveillance. Okay, surveillance endoscopy and colonoscopy if you have the polyps. So I give it to you 10 marks in this. It's an excellent answer. Very good. Now, next question.
Dr. Sachin, are you able to see the screen?
Yes, yes, sir.
Yeah.
So this is going to be a 6-year-old female child who presents to you with recurrent urinary tract infections. Ultrasound reveals a duplex collecting system and with a cystic lesion at the bladder base on the right side. Okay, it is a duplex system, but you can see a cystic like structure here below.
This looks like
So
a ureter
yes,
seal.
yes, excellent. So this is a ureterocele and a double moiety. More likely on the right side you have a ureterocele. So what is Weigert-Meyer's rule?
Sir, Weigert-Meyer's rule says the upper moiety of the ureter joins the distal bladder and or urethra, and the lower moiety joins the upper end of the bladder.
Excellent. I'll give it to you anyway. It is going to be a double moiety on the right side with an ureterocele and Weigert-Meyer's rule, classical anatomical relationship with ureteric insertion in a complex duplex system. Yes, the upper pole ureter inserts inferiorly and medially and often ectopic, prone to obstruction, like in this case, the ureterocele. The lower pole ureter inserts superiorly and laterally, typically associated with the ureteric reflex. Just put up this to let you know that whenever you have urinary tract infection in any child, be it male or female, an elderly age group. So if at all you have an antenatal diagnosis of a urinary tract infection, it is okay. So you look for any antenatal signs and then progressively look for radiological signs like that. Whereas it is an elder child, sometimes radiological signs may be missed, number one. Number two, always look for constipation. Bowel bladder dysfunction is one where recurrent urinary tract infection is always a possibility. If BBD is ruled out, always have a good radiological imaging with an ultrasound, and further you can proceed with either an IVP or an MCU, okay, based on what the investigation demands. Anyway, it is very, very good. So you get 10 points on that. So we'll just go to the next round, okay? Next round again, it is going to be more of a neonatal surgery. Round 13. So who's going to be the first one here?
Sir, can't see your screen. Are you displaying round 13? We can
Yeah,
still see the round 12 screen only.
just come back again, share the screen again.
Yeah.
Is it visible now, sir?
Yes, sir. You can put it in slideshow mode.
It's okay now?
Yes,
So
sir.
who's going to be the
Clearly visible.
first one?
So it is Dr. Badani again.
Badani, can you? I'll just talk you through. So this is a newborn male child who was delivered with an antenatal hydronephrosis and a poor urinary output, respiratory distress on day 1 of life. Physical examination: child is just dribbling of urine and a distended bladder. A catheter is inserted, draining a large amount of urine, relieving distress. And an ultrasound was done which shows a bilateral gross hydroureteronephrosis. And MCU confirms the diagnosis of post-urethral valve. The neonate's weight is 1.8 kgs. So it is a preterm child with a birth weight of 1.8 kgs. What do you think is the next step in management?
Sir, male newborn, posterior urethral valve, weight is 1.8 kg, not stable. So I like to do a percutaneous urinary diversion, maybe a nephrostomy, a percutaneous nephrostomy or something like that. So
You want to do a percutaneous nephrostomy where? Which side? Right, left?
on which side of the, like?
No, I'll just tell you. See, we have a post-urethral valve. So we know it is a post-urethral valve.
Yes, sir.
And what do you think is the gold standard for treatment of post-urethral valve?
So we have to fulgurate the valve, like we have to.
Yes. So now is in this case fulguration possible, not possible?
This is not possible because right now the baby is also not in a position to take up for a surgery. It's not possible in this case right now.
Why do you think so? Is there any specific reason you want to attribute to it?
Weight is less.
Okay, that is one very good answer. Yes, birth weight is less, but because the birth weight is less, is there any other reason we cannot take up for surgery?
So
child has no azotemia.
the catheter,
The respiratory
yes.
distress is relieved. Yes.
So when the catheter is put, there is a large volume of urine which has drained and it has relieved the distress.
Yes, excellent. So
now we can first do a percutaneous diversion, and then later when the baby is built up, we can plan for the definite surgery.
Look, now see what you're coming to an answer. Yes, the reasoning is right, but there is no role of percutaneous nephrostomy.
Percutaneous urethrostomy. Percutaneous urethrostomy.
You feel ureterostomy will help, okay?
Yes, sir.
Ureterostomy, you want to do it one side, two sides? Where do you want to do?
So one side.
But still the obstruction is there, right? Sorry, anyway, I'll just let you know. See, the child will need a vesicostomy. Why vesicostomy? Because within 1.8 kg, such a small minuscule infant, you will not be able to pass your cystoscope. The ideal gold standard treatment is fulguration of the valve. A cystoscopic fulguration of the valve is what we need to know. But because the birth weight is very small, it's only 1.8 kgs, miniature cystoscopes are not possible. So the indication for vesicostomy in children, one of the most important indication is extremely low birth weight. So hence vesicostomy is done. There is no role for nephrostomy in PUV, number one. Number two, if at all you're looking at something like an ureterostomy, then obviously your obstruction is still there. So one system is going to go down. You have no evidence of reflex there. If you look at the MCU, there is no evidence of reflex. So you don't have any grossly dilated or tortuous ureter. It is only a hugely distended bladder and a distended dilated urethra. Hence, the vesicostomy is what we are looking at. The role of ureterostomy is if at all the child has a PV valve fulguration or a vesicostomy with high grades of reflex, still child goes in for urosepsis in spite of valve fulguration or vesicostomy, yes, then ureterostomy may have a role. So there is no role of nephrostomy. And the other one thing you should know is PUV is a global disease. It is not just confined to the urethra. All your kidneys, ureters, bladder, everything is grossly affected. Okay, so ideally this child will benefit from a vesicostomy, but because you have already reasoned out it properly, I'll give you around 3 points, 3 marks for this, but the ideal should be a vesicostomy. Okay, now coming to the next question, number 2. Dr. Vyas, yes, this is a full-term newborn having an abnormal genitalia at birth. The phallus is very small with a severe hypospadias, which is the penoscrotal hypospadias. The gonads are not palpable on either sides. It has an ambiguous genitalia. what do you think is the next step in management?
Yes, this is likely female with the congenital adrenal hyperplasia. CH is the diagnosis, and likely we measure the enzyme 21 alpha hydroxylase enzyme.
Yes.
And after measuring it, we will make.
Do you think? I am telling the child is becoming sick. Child is becoming dehydrated. Has other abnormalities. Is there anything else we need to evaluate? I anyway give it to you. The answer is absolutely fantastic, right? I was just looking for a disorder of sexual differentiation, a severe penoscrotal hypospadias, non-palpable gonads. I was just looking for a disorder of sexual differentiation, but I've gone one step further. Yes, very good. And the other thing is, yes, we need to evaluate for the hormonal levels. But what we are more worried is the child is becoming sick because of electrolyte imbalances. We have to look for evaluation of an adrenal crisis. Okay, adrenal crisis one we need to evaluate because there is a salt wasting type and a non-salt wasting type. If the salt wasting type is there, we'll have to treat the child a little bit with more caution and efficaciously manage it in the newborn period. Otherwise, we might lose the child. Anyway, it was a fantastic answer. Yes, it was a disorder of sexual differentiation. Along with it, we do a karyotyping to assess the gender of the child, and further so we evaluate the enzymatic levels. But at that short of time, the earliest management should be targeted towards evaluation of adrenal crisis. Okay, so excellent answer. We're just going to the third one. Third one, yes. Who's going to answer this?
Sir, Dr.
Yes, sir.
Vyas, how many marks?
Sachin,
Yes,
you're
sir.
able to
Yes.
see this?
Yes, sir. Yes, sir.
So this is going to be a 10-day-old infant. Birth weight is only 800 grams. Born at 26-week gestation, the NICU. Develops feed intolerance, gross abdominal distension, bloodstained stools. The initial management, like in NEC, bowel rest was given. Child was put on iron antibiotics. The condition gradually worsened. There was temperature instability and abdominal wall erythema. An X-ray was taken which shows gross pneumoperitoneum, classical football sign, indicating some intestinal perforation. The infant is intubated on inotropic support. What do you think is the next best surgical intervention?
Sir, can you tell me Vyas marks?
10 marks, man. 10 marks. 10. Yes, Sachin.
Yes, sir.
So we know some perforation has happened. We know NNEC passed through different stages. Modified Bell's criteria. Child passes through initial just abdominal distension and temperature instability. Child goes in for impending perforation. Finally, perforation peritonitis. Now, child is in the last stage. Perforation peritonitis. The child is but very sick. The child is intubated on inotropic support. You're not able to shift it to the theater. So what do you think is the next best option? Yes, laparotomy may be the option, but the child may not withstand such a huge laparotomy and surgical procedure. So is there anything which you can do to the kid on the bedside?
Yes, sir. Sir, just putting the abdominal drain.
Yes, anyway, I give it to you. Yes, flank drain itself will suffice. So anyway, I'll give it to you because this is a bit complicated one. Yes, just a bedside peritoneal drain placement, a flank drain placement by will is more than enough in these babies. In fact, you will be amazed to see that many of these babies do not require a surgery because this perforation gets sealed spontaneously after the toxic fluid, the peritoneal fluid, which is causing so much of irritation, and then going in for sepsis, toxemia is relieved. These child may even come out without a surgical procedure with this temporizing measure itself acting as a relief for all these kids. But some of them, once they stabilize, the drain throws out large amount of fecal matter, the drain keeps on throwing out large amount of bile, the child stabilizes, weight improves, then probably the child may be taken up for laparotomy. But as in any other method, when there is a peritonitis, always relieve the peritonitis. Take out the fecal matter, take out the bile, the child will be going towards normalcy. Yes, a bedside peritoneal drain placement is mandatory in these children because it is a very, very small child. Child has got high inotropic support. The child has got severe peritonitis. So I give it to you 10 points on this. So yes, Gupta, the last question
Yes,
is
sir.
for you. This is a 3-day-old term neonate presents with recurrent bilious vomiting and feed intolerance since day 2 of life. It passed meconium on day 1, but now has a distended abdomen and a bleeding per rectum. Vital signs shows mild tachycardia, perfusion is borderline. Abdominal X-ray on day 2 reveals a paucity of gas in the intestine, but no free air. There is a classical double bubble sign. So, what do you think is the diagnosis and next line of management?
Sir, it is the jejunal atresia with the classical double bubble sign. Hello, am I audible?
Just go slow on it, ma. It is a double bubble, and you are making a diagnosis of jejunal atresia. It is the bleeding per rectum is there.
The double bubble sign is, sir, duodenal atresia.
So, do you think you will have a bleeding per rectum in any case of duodenal atresia?
3-day will begin present with recurrent bilious vomiting and feeding intolerance. Day 1, but now the distended abdomen.
There are two,
And
as I
sir,
already...
it can be due to the volvulus of the intestine, which can lead to...
Do you think duodenal atresia will cause volvulus?
No, sir. It is not called volvulus, but volvulus may lead to necrosis and can lead to the bleeding PR.
So I'll give it to you partly on this. I'll give you 5 points on this. But remember, the double bubble sign is not, I just put a hitch because double bubble sign is not classical for duodenal atresia, okay? Malrotation with volvulus can cause double bubble sign. In fact, it will cause double bubble sign whenever you have a malrotation with volvulus. So though annular pancreas, duodenal atresia, all of this cause double bubble sign, they will never cause volvulus, gangrene, distension of abdomen with the bleeding per rectum. So two things we always remember: if it's a term or a preterm newborn male child with an abdominal distension, dribbling of urine, you think of posturethral valve, number one. The same time, any child who presents with bilious vomiting in the newborn period, your first diagnosis should always be malrotation, because you diagnose it early, the volvulus is derotated, child will have a normal life. You diagnose it late, the entire bowel, small bowel, go in for gangrene, child may not have a normal life. So double bubble sign is seen in malrotation with volvulus. See, because I've put up all of this because child passed meconium, so there is no lower GI component into it. And again, there was luminal patency at some point of time. But now there is a bleeding PR. It is a malrotation with volvulus going in for gangrene. And that is why you have a tender abdomen, and along with it, the perfusion becoming borderline because child is going in for acidosis and a bleeding per rectum. So it is a malrotation with volvulus and gangrene. So upper GI contrast study initially done, and then you look at the position for the DJ flexure. If it is on the center or to the right of the spine, you look off for diagnosis of malrotation with volvulus. The contrast shows a classical COX-2 appearance in a volvulus, and subsequently early laparoscopy or laparotomy is mandated in these children with malrotation and gangrene. So thank you, dear friends. I just want to update you on the scores at the end of this round.
Yes, sir, sharing.
Yeah.
Is my screen visible, sir?
Yes, sir. Yes, sir.
Yeah. So Dr. Ayush Badoni, after 13 rounds, he is on 70. Dr. Ayush Vyas, he is on 82. Dr. Sachin, he is at 53, and Dr. Ayush Gupta on 35.
Excellent, students. So you have a long night to go. Anyway, you guys are doing extremely well, and really happy and proud that you guys are rocking all the subspecialties of general surgery. All the very best, friends, and I'll just invite the next presenter to take over the dais.
Yeah, hello everyone. So it's a long night. So we'll, without much ado, we'll begin with the neurosurgery questions. Am I audible? I believe I'm audible to everyone.
Yes, sir.
Yeah. So I'm gonna share my screen. All right. So my screen share is visible, right?
Yes. Yes, sir.
Yeah. Okay. Dr. Ayush Badani, the question to you. We have 2 rounds for neurosurgery. Round 14 will be for based on neurotrauma, and then round 15 will be on elective neurosurgery. These questions are basically either you know or you do not know. There is nothing in between. So we'll begin with Dr. Ayush Badani. So this is a CT image of 25-year-old male who presents to you following an RTA and a neck pain. There is no neurological deficit. So what is the diagnosis?
So could you please repeat? The screen has frozen. I can still see only round like one written.
You want me to repeat it, or has the screen changed?
So yes, sir. Now it's okay. So could you please repeat the question, sir?
Yeah, a 23-year-old male presents to you with RTA and only neck pain. There is no neurological deficit. Imaging as shown here. What is the diagnosis?
So C1 fracture, hangman type.
No, I'm afraid this is a type 2 odontoid fracture. Okay. All right. So to Dr. Ayush Vyas, this is the image of a 40-year-old male who presents to you after 3 months of trauma, and he is presenting to you with a progressive spastic quadriparesis. And this is the X-ray cervical spine, which shows a particular problem. And what is the diagnosis? Dr. Ayush Vyas?
Likely, sir, Atlas and axis dislocation.
Very good. So it is an atlantoaxial subluxation. Very good. So 10 marks to you, Dr. Ayush Vyas.
Sir, any marks to Dr. Ayush Badoni?
No, no marks to be awarded for Dr. Ayush Badani. 10 to Dr. Ayush Vyas. And Dr. Sachin?
Yes, sir.
This is a image of a 16-year-old boy who presents to you following an RTA. And you do an axial CT and you find this. What is the diagnosis? CT cervical spine?
Yes, sir. This looks like axis.
I would like to have the name of the fracture.
Yes, sir. Hangman. Okay. Jefferson's fracture.
Very good. It's a Jefferson's fracture. Very good. So 10 marks to Dr. Sachin. Dr. Ayush Gupta?
Yes, sir.
Okay. This gentleman, a 60-year-old male, presents to you following an RTA. He walks to your ER complaining only of neck pain. There is no obvious neurological deficit. An X-ray cervical spine is shown to you. What is the diagnosis?
Sir, it is the C2 fracture, sir.
Be specific.
Yes, sir.
Can you be a little bit more specific?
Sir, it is the C2, sir, dense fracture.
No.
So,
It's a hangman's fracture. What you are seeing is an hangman's fracture where there is a fracture involving the pars intraarticularis of C2. So the C2 is subluxated over C3. So this is a classical hangman's fracture. So unfortunately, no marks to you, though you identified it as a C2 fracture. All right. So the next round, it's again an image-based round to Dr. Ayush Badani. Dr. Ayush Badani?
Yes, sir. Yes, sir.
Yes, ma'am. So this is an image of a 40-year-old female who presents to you with headache, hearing loss, and you do an MRI brain, and you identified this type of lesion. So what is the diagnosis?
Cerebropontine angle tumor, likely
Very
a
good.
sonoma.
Very good. So 10 to you. 10 to Dr. Ayush Badani on round 2. Dr. Ayush Vyas?
Yes.
This is the image of a 40-year-old female who presents to you with left-sided weakness, and you do an MRI brain and you find this. What is the diagnosis?
Meningioma, likely.
Very good. It's a large meningioma. Very good.
Large.
Dr. Sachin?
Yes, sir.
Okay. A 60-year-old male presents to you with a headache and forgetfulness. There is some weakness on the right side, and you do a MRI brain and you identify this type of lesion. So what is the diagnosis?
Glioblastoma multiforme.
Very good. It's a butterfly glioma. It's a glioblastoma multiforme. So 10 to Dr. Sachin.
Sir, Dr. Vyas also 10, right?
10. All of them have got 10 in this round. Dr. Ayush Gupta?
yes, sir.
This is a image of a 65-year-old male who presents to you with seizure, new onset seizure. He was not a known seizure disorder patient. He has headache and seizure, and you go on to find an MRI which is showing a picture like this. So what is the diagnosis?
Looks like a pilocytic astrocytoma.
A 65-year-old male presents to you with new onset seizure. Why would you go for pilocytic astrocytoma?
I have no idea.
Okay, that's good. So this is a lesion that was right over the gray-white junction. A 65-year-old male new onset seizure disorder. The first thing you have to keep in mind is whether it is a primary brain tumor or it is a secondary brain tumor, which is more common. So it's more likely to be a metastasis. You can see the tumor to be more well-rounded at the gray-white junction. So this is actually a metastasis. So unfortunately, no marks to you, but you did well. All of you did well. So with this, I end the session on neurosurgery. Can you update the scores, Dr. Ravi?
Yes, sir. Sharing my screen. So after 15 rounds, Dr. Ayush Badoni is on 80, and Dr. Ayush Vyas is on 102, and Dr. Sachin at 73, and Dr. Ayush Gupta at 35.
All right. I now leave the stage to the next person. Thank you.
Thank you, sir.
I think someone have to make me as a host, please.
Can you make Dr. Dr. Sakirajan the co-host of the session? Are you able to share the screen? Are you able to click on share?
No, sir, I couldn't share it.
Vinod, are you there? Yeah. Yes, sir. You have been
Sir, now
given
you
the
can now you can
Sure.
share the screen.
So hope my screen is visible for everybody, sir.
Yes, sir.
Yeah. Okay. So it's a long time. So we will go directly with the questions. Now it is round 16, and we'll go with cardiovascular and thoracic surgery first. So to the first person, name the newer and commonly used technique to correct the hemodilution that occur in cardiopulmonary bypass and return the concentrated blood into the circulation. So this is the question. Name the newer and commonly used technique to correct the hemodilution that occurs in the cardiopulmonary bypass and to return the blood, concentrated blood back into circulation. So your time starts now, man.
Commonly used technique to correct hemodilution and occur and return the concentrated blood back into the circulation. Sir, ultrafiltration?
Yeah, there's a common broader term, which is a newer type.
So salvaging the cells and centrifuging it back?
You're right. I wanted a name. We have two types of ultrafiltration.
I remember ultrafiltration cell salvage technique.
Yeah, you're partially right. There are two types. The newer one is modified ultrafiltration, and the older one is conventional ultrafiltration. That is, so you can get 5 marks for this question.
Okay.
So the next candidate, a 3 months old baby with pulmonary atresia and with the VSD. Okay, and the baby was planned for an intracardiac repair, and intraoperatively MAPCAS, that is main aortopulmonary collateral arteries, are identified, and confluence is created, which is anastomosed to the RVOT. At this moment, whether we can close the VSD or not, this can be checked by a intraoperative maneuver. What is that? So I'll repeat the question again. Patient has pulmonary atresia and VSD. Pulmonary atresia means the pulmonary artery has not developed properly, as you can see in this image. And as there's pulmonary atresia, there will be MAP caps, that is main aortopulmonary collateral arteries from the aorta supplying the pulmonary arteries. So these collateral arteries were identified intraoperatively, and a confluence will be created, which will be anastomosed to the right ventricular outflow tract. So we have corrected the pulmonary atresia. Now we are going for VSD. So whether to close the VSD or to leave the communication, this will be decided by an intraoperative technique. Name the technique, please. For more clarity, I'll give you some more information. When patient has a pulmonary atresia and VSD, the right ventricle will be decompressed through the VSD, because blood will flow through right ventricle to left ventricle. Now, if we are closing the VSD, all the blood from the right ventricle will go into the pulmonary artery. This is the clue you get. Name the technique which is used to. Yeah, please.
Pulmonary flow test.
Yeah, you're right, man. You get 10 marks. So the answer will be pulmonary flow study. Here we will cannulate the pulmonary artery, and we will, through cardiopulmonary bypass machine, we will allow flow through the pulmonary artery, that is newly created pulmonary artery, and we will check how much amount of flow that allows with the minimal amount of pressure. If that is okay and it is enough for the perfusion, then we can close the VSD. If not, we can go for a fenestrated patch closure of VSD, or we can even leave the VSD open. So the next question for the so a 50 years old male patient was brought to a casualty with a penetrating chest trauma. So third person is online, right, sir?
Yes,
So
yes.
yeah.
Yes, sir.
A 50 years old male patient was brought to casualty with a penetrating chest trauma. On further evaluation, patient is suspected to have a ventricular free wall injury, and of course, patient is hemodynamically unstable because of this injury. And as patient has been planned for a surgical procedure, and surgical repair was done successfully. So post-procedure, blood gas analysis was done. This is the main part of the question. Blood gas analysis was done. From the radial artery, the ABG shows saturation of 100%. The blood gas analysis from the pulmonary artery shows 30%. With this blood gas report, what will you infer? That is the question. Why such a difference? Whether it is a normal or anything you can infer from this. In this above scenario. Any guess, please? Any case, man? Just try something.
Sir, the penetrating injury.
So first half of the question is just a clinical scenario. The main part of the question is the second paragraph.
Sir, the injury might have caused pulmonary embolism.
I think we can, I will answer the question. So you don't get marks for this question as time over. So pulmonary artery saturation means it is the systemic venous saturation. Systemic venous saturation. Which means if artery or aorta contains 100% of oxygen, it will go throughout the body, and body will take its need, and then the remaining will be in the systemic venous circulation. Systemic venous circulation. So the saturation here is what we get after all the body's requirement is met. If it is less than 40%, then the circulation is being affected. The circulation is low. So this happens in case of low cardiac output syndrome. Or in cardiogenic shock. So from this ABG, that is blood gas analysis, we can infer that patient is in low cardiac output syndrome or cardiogenic shock. Okay, so this is the answer. So we will go for the next candidate. So next candidate, is he available right now? Yeah. So a patient presented to OPD with the dyspnea and exertion and poor weight gain. So on examination, patient had a bell-shaped chest. Okay, and radiological imaging showed horizontal orientation of the ribs, and pulmonary development is poor, and pulmonary function test PFT shows restrictive pattern, and this is the X-ray of the patient. And what will be your diagnosis? So bell-shaped chest and horizontal orientation of ribs and poor pulmonary development, and PFT shows restrictive pattern.
June syndrome?
Yeah, you're right, man. Good. June syndrome is the correct answer. So you get 10 marks. So we will start with the first person again. Round number 17. We'll go with vascular surgery. I think first candidate is available, right, sir?
Yes.
First candidate.
Dr. Ash.
So I'll go with question. A 60 years old male patient was on a routine health checkup, showed up with a 75% stenosis in the left carotid artery and 30% stenosis in the right carotid artery. Patient is asymptomatic. He came for a routine health checkup. What will be the ideal line of management? So this is the image showing the duplex image showing the occlusion around 70% in the left carotid artery, internal carotid artery.
Showed 75% stenosis of the left carotid artery and 30% stenosis on the right carotid artery. But the patient is asymptomatic. What will be the ideal line of management? Sir, for the left carotid stenosis, like to go for a carotid end arterectomy?
Yeah, you're correct, man. Even if patient is asymptomatic, more than 70% of stenosis, we are supposed to go with end arterectomy. Okay.
Yes.
So you got around 10 marks for this question.
Thank you, sir.
So candidate B, a 35 years old female presented with varicose vein. On examination, the varicose vein was pulsatile, and patient was a known case of valvular heart disease. What might be the reason for pulsatile varicose vein with the above clinical scenario? I'll repeat the question again. 35 years old female patient with varicose vein. On examination, the varicose vein is pulsatile. Patient is a known case of valvular heart disease. What might be the cause for pulsatility of the varicose vein with above clinical scenario? Yeah.
Likely, sir, due to tricuspid.
Yeah, you're right. If patient has a tricuspid regurgitation, patient will have pulsatile varicose vein because of the back pressures. Because of the back pressure, because of tricuspid regurgitation, when the right ventricle contracts, the blood will regurgitate into right atrium. This will add pressure into the SVC and IVC, and because of the back pressure, patient will have pulsatile varicose vein. So you also get a 10 marks. So next question for the third candidate. Hope is available, sir.
Yes, sir.
So during the surgical repair of abdominal aorta aneurysm, the left renal vein was accidentally ligated and divided. How will you proceed in this scenario? During the surgical repair of abdominal aorta aneurysm, the left renal vein was accidentally ligated and divided. How will you proceed in this case? Any guess, please?
What is it?
You're going to reoperate or can wait and watch?
I can leave, sir.
Then you have to answer why.
Sir, left renal vein have other drainage from adrenal vein and
yeah, there is only less than 5% of person will get renal dysfunction if we accidentally ligate and cut the left renal vein.
Can be left.
So we can go for wait and watch.
Yes.
Because there may be collaterals in this case of aneurysm. Okay.
Collaterals.
Yeah. So this is the reason why we can wait and watch. So as I gave some clues for you, I can award you with 5 marks for this question. So the next candidate.
Yes.
A 38 years old female was admitted with the complaints of limb edema and pain. So radiological imaging showed a left iliofemoral venous thrombosis with occlusion. Patient was planned for surgical intervention, and intraoperatively, as you can see in this image, the left common femoral vein is anastomosed to the opposite side normal femoral vein through the long saphenous venous conduit. Name the procedure.
It's a Palma operation.
Yeah, sure. You're right, man. You get 10 marks for this question. So that's the end of the this round. And you all answered well. Congrats and go ahead for anything. Thank you. So organizing people.
Yes, sir. Thank you. Thank you so much.
Yeah,
Karthik,
thank you.
Karthik, can you share the screen and the scores? Yeah.
Is it visible, Ravi?
Yeah, I can see the scores.
Yes.
Yeah. So Dr. Ayush Badani is on 95. Dr. Ayush Vyas on 122, leading the pack. Dr. Sachin at 78, and Dr. Ayush Gupta on 55 after round 17. Are there any more rounds after this, Karthik?
No. I think we didn't see the quiz master. We didn't count in this. That's why it is counted as 17. But actually, the rounds are 18.
Understood. Yeah. So those are our final scores. thank you all for attending this and being very patient with us as well on a Sunday evening. Uh, all of you have performed exceptionally well, and I thank all the quiz masters as well, right from Dr. Raj Mahendran to Dr. Balaji, Dr. Venkatesh, Dr. SSK, and Dr. Isaki Rajan, and yeah, so primarily the people who have conducted this, Dr. Ragul with pediatric surgery. I hope you got a lot to learn today as well. Not only it's not only about winning and losing, but I hope you also got a lot to learn today as well. So to the top three winners, as promised, we will be delivering our gifts, uh, right? And the other participants who made it to the round two till here will also be getting free access to our residency as well as NEET SS courses. So thank you all. Anything, yeah, any one of you wants to say, how was your experience interacting with these top clinicians? The floor is open.
Thank you so much, sir, for conducting this quiz. It was very random. I stumbled upon the quiz on the DocTutorial app. I had no idea regarding it. And I vividly remember just after our MS theory exams, we were going to Kolkata, and in the train, I just gave the exam with no hopes. And I'm very happy that I could make it to the finals. I did learn a lot of things this time. I should be more patient. I lost a lot of marks because of that. But I'm really grateful. It was a very grilling experience, 18, 17 rounds, so many questions, CTVS, neurosurgery. At one point, I had a brain freeze, but then it was a very good experience. Thank you so much, sir, Rajamendran, sir, everyone, sir, for making this happen, sir. Thank you so much.
I don't know how you felt as a candidate, but during medical oncology, I also felt I was grilled. So I felt that was the toughest round. Those were the toughest rounds that Dr. Balaji dealt with. Dr. Rajmahendran gave us a lot of surprises with the newest editions of the books, right? If you are not up to date with that, you will have found a difficult time for yourselves, right? But overall, I hope the quiz was engaging for all of you, and it was also enlightening in this at the same time. Thank you so much, Dr. Vyas, Dr. Gupta, Dr. Badani. The only reason I am calling you with your second names is because all of you are Ayushis, and Dr. Sachin.
So many Ayush, sir.
Yeah, yeah. Thank you so much for this.
Thank you so much.
Karthik from our team will be getting in touch with you for your details to get the activations done and for the gifts to come through.
Mm.
Thank you.
Thank you.
What will the fourth one be getting?